Okay, so I hope folks have had a chance to read through the whole schedule. I'm not going to go through the whole schedule, but there are just some highlights that I want to cover. We have Zoom class every Monday night. We will have Zoom class Monday night at 5:30. We always try to start at 5:30 on the dot. And we will always end by no later than 8:30. We encourage while you're home. We love if your screens are on, so that we can see you. It helps us get to know you so that when we see you in person, we know who you are. And again, we encourage discussion, stuff in the chat. We love it. It'll make for a fun class. Also, step away, have your dinner. I would venture to guess most of you are either working, going to school, doing stuff all day. So have your dinner, do what you need to do from that end as well. I want to just cover what it's going to take to successfully complete this class, because I think that's really important to stress. So to successfully complete this class, you have to finish with a minimum of a 70% average. That's passing because that's what the National Registry considers passing. So you have to be able to achieve a 70% or better in class to pass the class. The grades of your class will consist solely of 3 exams, a final exam, so 3 exams and a final. There will be 4 online learnings. Those 4 online learnings that I emailed you about last week. So ICS 100, ICS 700, hazmat, and mandatory reporter. Not knowing you all in person, but knowing that many of you are involved in public safety, many of you may already have some of those classes. So if you've already done them, all you have to do is send me a copy of your certificate. You do not need to retake the classes again. So if you've already had them, like I know many of you are firefighters or other kind of first responders, feel free to send those certificates along to me, and then you don't have to redo them. And then the last piece of successfully completing this class is demonstrating competency in your skills. So through the course of this class, we're going to teach you a lot of skills, from how to do CPR to helping someone breathe to controlling bleeding and everything kind of in between. You have to demonstrate to us competency in those skills. And through the course of the class, every time we do lab, we'll be evaluating your competencies. And so that's why the labs are so important. It's important that you participate, that you engage, and you practice your skills. And we know it can be intimidating doing skills in front of people that you don't know, but everybody's in the same boat learning skills. So you really need to be participating to achieve that competency. And in the schedule is you'll see a list of the skills that you'll be taught through this class, as well as how many times you need to demonstrate competency in those skills. So if you ever have a question about that, those are right there in your schedule. So I encourage you, as we get going with those, if you have questions, to kind of revisit that. So that will help you. So those are really the big things that you have to do. The last piece is that you have to have 5 patient contacts, meaning you have to, if you are with a service, which many of you are, you're going to be going on calls while you're taking this class. You're going to have interactions with patients. There'll be some paperwork that I'll send out later on where you can document those patient contacts, have them signed off by a preceptor at your service, and then just send those in to us. And that's how you'll get them. For those of you that are not with a service, don't panic. You don't have to be with a service to take EMT class. And towards the end of the class, we will set up a simulation day where we will do simulations, and you will be able to get an experience that will simulate your patient contacts. And we're allowed to do that for folks that are not on services. Through the course of the class, you know, as you're going through class, if you're interested in getting on a service, if you're interested in getting involved and you're not already, I highly encourage you to reach out, have a conversation with me and say, hey, I'm interested in getting on a service. Can you help me? And I guarantee I can help kind of direct you in one way or another. So I encourage you to do that. So are there any questions about what it's going to take to pass class? Okay. When we are in lab, if you are with a service, you should wear your uniform. And really all that needs, you know, if you have tech pants, wear tech pants. If you have a service shirt, wear your service shirt. If you're not with a service, that's fine. But we have to have appropriate clothing. So take a look in the syllabus for what kind of clothing you should be wearing. And then I think that's all I wanted to cover as far as the kind of the highlights, really what it's going to take to successfully complete this class. So unless folks have, yeah, go ahead.
Excuse me. Where are the, yeah, I just had a brain cramp. I'm sorry. When we do our testing or our practical labs, there we go. Where are those going to take place?
That is a good question. Right now, we're planning, they're going to be held in Chittenden County. Okay. We're still trying to see if, I know some of you are from outside of Chittenden County, and if there's enough of you that we can put together other practical sites, we will consider doing that. So if there's a group of you that would be traveling, let's say from the Rutland area, or there would be a group of you that would be traveling from more southern Vermont on the other side, reach out to me. And we can explore setting something like that up. So, but in the meantime, this first one will be here in Chittenden County, and I will send out all directions and locations later this week. Okay, let me hold on a second. Can you all see my screen? Somebody, Carrie, you're someone I can see. Can you just give me a thumbs up if you can see my screen? Thank you. All right. So this is where all the resources and information that you're going to need for your class are. And so I just want to cover this really quickly before we get started tonight. So under weekly assignments is where I will post weekly assignments. So every week, I usually do it on Sunday mornings, just so folks know when I do it. On Sunday mornings, usually the first thing that I will do is I will come in and I will post your assignment for the coming week. So as you log in under weekly assignments, and this is your view, this is a student view, right up here at the top, so you always know where it is the Zoom link for class. So it's the same Zoom link every single week, and it's easiest for you if you log into Jones and Bartlett and you come here and you click on weekly attendance and log into Zoom this way, this will log your attendance in class. We keep track of your attendance in class, and this is a way to log your attendance. So when you click on here and click on the link, the system marks that you are present in class. This will always be right up here at the top, so it's easy for all of you to find. So it's always going to be there. And then down under here are the weekly assignments. So I know a lot of you saw this last week and started doing a lot of these online learnings. So there was week 1 assignments. There was that critical thinking question I posted. And then right here, it was what I posted for this week. These will be what we'll be covering this week. And when Kevin starts lecturing, we're going to jump right in tonight. I guess this is my view. And then there is a weekly quiz. I do post weekly quizzes, not every week, but sometimes I will post weekly quizzes. These quizzes do not count. They do not count towards your grade. They're a good way for you to judge how you're doing, to see how you're doing, and to measure how you're learning your information. But again, they're optional. They do not count. I'm not counting them towards your grade. So all of those will be posted here. There's the student view. And as the weeks go by, more weeks will be added in. And I will probably start hiding some of these so that you're not just overwhelmed with all the information that's going to show up there over 18 weeks. Then the last thing is under resources I wanted to post is there are a variety of resources here for you that we will cover through the course of the class. So the first one is the syllabus. So the revised syllabus that I did is posted here under course syllabus. Here under weekly presentations, and they are already posted, are the PowerPoint presentations that we will be doing in class. I know for some students, whether they want to look at them ahead of time, some people like to print them out and take notes on them. So for whatever works for you, we've already posted the presentations through the course. So all of our presentations are there. For all of you that may have already logged into Lights, and if you haven't done that yet, you should. But here is the Vermont EMS Student Manual. This is a manual put out by the Vermont EMS office. It talks about being a student in an EMS class, your rights as a student, what you can expect. If you might need an accommodation either for class or especially for National Registry testing. It talks about how accommodations can be requested. It has a lot of good information in it that you might want to take a look at. The next piece under here are NREMT skill sheets. At the end of your class, if you decide you want to move forward for your certification. Certification is a two-part process. One is a cognitive exam and one is a psychomotor exam. And these skill sheets are the sheets that are used in that exam. So, and we'll revisit these sheets in class as you're working on your skills and working to develop your competency. So as we get into labs, we'll explore these a little bit more, and they're great to help you prepare for the National Registry exam. Next under here is the 2020 Vermont EMS protocols. So this is really the scope of practice for EMTs in Vermont. You're being taught a national class, so we follow the national guidelines. We set the national EMT instructional guidelines, which are a little bit further down. That's what you're getting for a class. Vermont is a national registry state, and so that's what we teach is based off the national guidelines. But as we're going to talk about next week, states can do their own things. And so Vermont has its own set of EMT protocols. And these are the EMS protocols for Vermont. You're taking class at an interesting time because these are the 2020 protocols. They change every 2 years. And so there's a excellent possibility that these protocols will change while you are taking class. And if that happens, we'll make sure that you have all the information. By the time you're done with this class, we will have taught you the national scope, but we will have also introduced you to the EMT Vermont scope of practice. Underneath that is the clinical forms, and that'll mean more when we start talking about your patient contacts. So the paperwork for patient contact is under clinicals. The EMT instructional guidelines, that's kind of the outline that we follow when we teach your class. This is set by the National Highway Transportation Safety Administration, who actually sets the guidelines. Down here, these are just practice tests that we will that you may want to use towards the end of class, and don't mind week 3 assignment. That'll show up back on your weekly assignments. So and then under here there are simulations that you can try. There's some really good simulations. There'll be some as part of your weekly assignments as we get into talking about medical and trauma. There's some great virtual ride-along videos that you might want to explore. And then there are all the chapters of the book. For each chapter of the book, there are learning objectives. There's the book where you can read it. There's the book, if you prefer to listen, there's audio book, so you can listen to it. There are flashcards, and there are PowerPoints if you're so inclined to read the PowerPoints. And then almost every one of these chapters also comes with its own quiz. Those are also all optional. I don't count them. They're for you to help you guide your learning and see how you are progressing. So I'm going to stop my share and see if folks have any questions.
I have a question.
Yeah.
So mine looks different. I don't have the weekly assignments or the resource page on my thing. It just goes straight into updated simulations, the ride along video, and then simulations and test prep, and then all the chapters. So I don't know how to access that part.
Megan, you and I should do a separate Zoom if possible within the next day or so, so I can see it.
Okay.
I'm wondering if this is how you logged in. So let's you and I try and figure that out.
Okay, thank you.
Yep.
Chris, how much do the standards usually change? The protocols change every 2 years. Is it usually a large change or just small tweaks?
It usually depends on the level, Kathy. That's a really good question. Sometimes they may add in maybe one new medication that at each level that maybe they can provide. Sometimes they may add in a new skill. It's not usually a tremendous amount of changes. EMS is very research driven. So the things that we learn in EMS and the things that we do in EMS, if we realize that if they realize that something works better, they will add it into our protocols. I'll give you an example. When I got into EMS, you would never tourniquet anybody, because if you put a tourniquet on, they would get gangrene and they would lose that limb, and that's that. So you only ever put a tourniquet on if there was just nothing else you could do. Now it's standard because we've learned through the military that tourniquets save lives. And so now, we're going to teach you how to do tourniquets. So it's things like that as they happen along the way. I don't think that there'll be too many differences. There may be a change to a medication, maybe another skill, but not a lot. It won't be tremendously different. I'm not sure when. I just asked somebody the other day, hey, do you know when? And they said, maybe October, but probably not. So we're probably looking more towards like November or December.
Thank you.
Yeah. All right. Kevin, are you ready?
Yeah, so while you were doing that, anytime I tried to turn on my camera, my Zoom would crash. So I'm going to turn it on and we'll see if it stays on. If
Okay.
not, you guys will just have to listen to me instead.
You're there.
Okay. Let's see. Can you see my screen?
Not yet. It's still black.
Can you see it now? All right. Let's try that again. Can you see it now?
Nope, it just says you're started screen sharing.
Huh. See, that's a new problem. That wasn't the problem I was expecting to have. All right, give me 1 sec.
Technology.
See, everything was working fine until you called on me. Apologies, everyone. This isn't usually how I perform. I usually don't have such problems starting. All right, let me join back in. I'm going to log out, join back in.
While we're waiting for Kevin, do folks have other questions that I can answer while we're waiting?
I have a question.
Yeah, go ahead.
Can we, when we practice the weekly quizzes that you don't grade, can we retake those
Yes, you can.
over just a,
Yep,
okay.
you can take them as many times. That's a really good question. I'm glad you brought that up. So the weekly quizzes, you can take as many times as you want.
Okay.
When I post exams, I will set the, hang on 1 second. I will set them so that you can take them once. However, if you don't pass them, I will reset it and let you take it again. All things in EMS in EMS classes, you can usually have up to about 3 chances. The National Registry gives you 3 chances, so we will give you 3 chances.
Very
If
good.
that makes sense.
Yeah.
Yeah.
Will we get a hard copy textbook this upcoming weekend?
If you prefer one, if you could just email me and let me know.
What level is it? What volume are we going off of?
11th.
The 11th?
Yep.
Is it,
Kevin, we can see it now.
Great.
If you have an older book, it's okay. Books don't change that much,
Okay.
book to book, because even when things change at the national level, they're usually not significant changes.
okay, I have an 11th and I have a 13th edition.
You're all set then.
Okay, perfect. Thank you.
Yeah.
Okay, it's stable and you guys can see me. That's correct.
And we see your presentation as well.
Perfect. Awesome. So as you guys can see, we're going to be talking about patient assessment. That's really what we're going to get into. And this is a huge part of being an EMT. So we're really diving in head first. If you have any questions, please feel free to just unmute and say, hey, Kevin, there is a raise your hand function somewhere in the Zoom bar, or just put it in the chat. And if it's something that we should talk about sooner rather than later, Chris will just let me know. So please do not hesitate to interrupt me. Questions are really what makes this presentation fun to give. So please ask. So we're just going to start. So we do an assessment. We use assessments on every single call. Anytime that we are sent out the door, whether it's on a fire truck, on an ambulance, whether we're walking out our own front door and something happens, we need to assess what's going on. So there are going to be a bunch of different assessments that we're going to do. There are going to be some that are more important. There are going to be some that you use every single call, and there are going to be some that you kind of have to fall back on if the situation arises. So what does a good assessment make us as EMTs? We go onto a scene and doing an assessment, what does that make us?
It makes us aware of the situation we're walking into.
Yeah, so it makes us understand what's actually happening, and hopefully that's what's going to happen. We might need to do more assessments to figure out exactly what's going on. But yeah, it helps us understand. What else?
gives you a direction for patient care?
Yeah, it tells you what you're likely going to have to do with your patient. What I like to think that this makes us is this really makes us medical detectives. People call us right after something happens, and we get there and we need to try to figure out what exactly happened so that we can help this patient. That's kind of what our job is. We're not going to get, bogged down on the nitty gritty of like, okay, how many steps did you take from here to there? That kind of assessment is too far in detail, but it can really tell us, okay, if we're looking at a car accident, where did this car come from? How fast were they going? Where did they impact? Versus we get on scene and somebody's bleeding a bunch. Hey, what caused that bleeding? Is it a danger to me? Is it a danger to my crew? Or was it an accident? Something along those lines. So right off the bat, here's a picture of a scene. We're at the first part of our assessment, right when we show up on scene. What about this picture right here is notable to you? What do you see on there and say, I should consider that important?
Stability of the car.
Stability of the car. Okay, what about it? Is it stable or is it not stable?
Doesn't look very stable.
Yeah, depends if that orange thing in the background is like securing it to, like a truck or something. But
yeah, so what we can say is there has been an attempt to stabilize this. We don't know if it's super safe. Yeah. What else?
There might be wires under it because it looks like a telephone pole in the back.
Sure. Yeah, there might be some danger, right? If those firefighters are down there, I'm hoping that they have taken those steps to control those wires, but definitely we don't want to just say, oh yeah, absolutely, everything's safe. Keep going. What else?
There could be looks like there gas leak or something. Traffic.
Yeah, so I heard two things. I think Nicholas there said maybe there's a gas leak if that car's tank was punctured or something. And then Carrie, I think I heard you say they're on the side of on the road, right? Traffic could be going by. Yeah, exactly. You guys are all thinking of the right thing. The first thing that we always have to ensure before we go onto a scene is it safe? Is it safe for us to actually come onto scene, right? If we're acting in capacities as EMTs and we do not have the equipment or the training necessary to be the first people into this car, it could lead to us getting severely injured, our crew getting severely injured, that patient going from being okay to being not okay, to being dead, if we tried to do something that we are not able or prepared to do in an unsafe scene, right? So you're going to hear this a lot from me and from all the other instructors as we go along through this class, but scene safety is always paramount. It's the first thing that we're looking for anytime we go on to any scene whatsoever, okay? Just keep that in your mind. The next thing that we're looking for is what we call an MOI or an NOI, so a mechanism of injury. So with this call, right, what would you say the high likelihood of that person being injured is?
Highly.
Yeah, pretty highly likely, right? That car looks pretty damaged. It's on its side. It's off the side of the road. What might be a highway, right? High speed. So mechanism of injury here is it's high. That person is likely injured. Another thing we can say is like suspicion of injury or suspicion of something like that. Okay, hey, you're looking okay, but if you came from this car, right? I don't know. My suspicion that you're injured is pretty high. The other thing that we're really going to want to consider is the number of patients. I'm sure everyone here has at least seen an ambulance, if not been in one. We only really have space for max one patient, maybe two on a good day. If one is severe, it can lay down on the stretcher. The other one can sit on the chair. We're not overcrowded. If there are more patients than that, we're kind of out of luck, right? How many people do you think could fit in that truck or that car that fell over? Probably 7, 8. And then, depending on if they're following the rules of the road and legal stuff, right? You could fit way more people in there. I've been to a circus. I've seen a clown car, okay? I know exactly how many people can fit in a car. So just us seeing that car right there should be a worry. Oh boy, there are at least 7 to 8 seats in there. We have 2 that we could potentially bring somebody to the hospital with. We're going to need, what's this? Extra resources, which is our next thing in the scene size up. Okay, is it safe for us to go? How bad does it look? How many people are we going to be concerned about here for treatment? And do we need extra help? Right, if we're the first people on scene as EMTs and we see that, it's not safe for us to approach, but we're going to need to call our friends, the fire department, to come and stabilize it for us so we can actually get access to our patient. But they're not going to come unless we ask them to. Or they're not going to come unless they're notified, right? So that's another and very important thing in our primary or our scene size up. Right after scene safety is, what do we need to be successful? And then finally, another thing that we're going to consider is, do we think this patient has a neck injury? And that's what we mean by C-spine. So your cervical spine, the really important vertebrae in your neck, which really support our life functions. If somebody has a neck injury, that's going to really change how we're going to have to treat them, how we're going to have to go about this call. So especially in a call like this, we're going to consider C-spine, right? We're going to say, as somebody is in a car accident that bad, we want to make sure that nothing is wrong with their neck. So that's our scene size up. That's that first step. And this really kind of can happen as soon as you see the scene. This isn't necessarily that we show up, we get out of our ambulance and we take like a full pace around the scene. We're not going to do that much detail, but you can do this from inside the front, looking at the windshield. Imagine that you drive up in a car and you see that. You can say, wow, the scene is not safe. Those firefighters are making it safe though. Good thing we had those additional resources. Hopefully we only have one patient. Let's ask. And I think we should consider C-spine. It takes you that quickly on a real call, but we do want to practice just verbalizing that we're saying, or we're thinking about those things. Okay, so that scene size up, very important. Next, what we're going to move on to is really actually when we start talking to our patient or when we come in contact with them. So the moment that we actually start talking to our patient, that's really kind of when our primary assessment happens. So it's a quick but very important assessment. So again, just like scene size up, we're not going to be in our primary assessment. We're really looking for the things that matter to us the most. It's all about order of operations, right? So what this is used to find is life-threatening injuries. So things that we can fix or not fix in a quick motion, quick next couple minutes, that can determine if the patient is going to walk out here alive or something bad is going to happen, right? So what might you consider to be a life-threatening injury or illness?
Major bleeding.
Major bleeding, you read my mind. Yeah, if somebody is bleeding a lot, they'll die in the next couple minutes. If they don't get interventions, if they don't have help to stop that bleeding, they will die pretty quickly. So a primary assessment, right? You show up on scene, you see a lot of blood, you see a leg that it's coming out of. Hey, let's stop that. Let's fix it. Let's address that right now. That's our primary assessment. What else?
Neck injury.
Respiratory distress.
Okay, so I heard neck injury and I heard respiratory distress. Absolutely, right? So if somebody's got a neck injury, you know that. I did. My back? Nope.
We see your screen still.
Can you hear me?
Yep.
Okay, so it's just like coming in waves, I guess. Okay, so life-threatening bleeding, a neck injury, you know, might not be like an immediate life threat. It's definitely a high mechanism of injury, and it's definitely a super big concern. But if we take appropriate
Kevin, can I
precautions,
ask you a question?
yeah, shoot.
Sorry, I'm not clear on your use of mechanism of injury. It sounds like
Yeah.
when you say mechanism, like, you know, like the car crash would be like, you know, a lot of physical trauma, but it sounds like you're using it a little differently. Could you explain that?
So mechanism really just means how it happened, how an injury happened, what caused the injury. So I guess when I said neck injury, I may have said mechanism of injury. What I mean there is that it is just a high suspicion. If they've got a neck injury or neck pain, that tells us, oh boy, they likely have a serious injury. We want to take precautions to mitigate it.
So you're using mechanism as like the higher force the mechanism was, the more likely there is an injury. So you're using it as like kind of an odds thing. Is that right?
Sure. I'm using it as the term that we use it in EMS, which is a description of or an assumption of how the injury happened and how likely we are to see a serious injury. A fender bender is a small or less high risk mechanism of injury. We see somebody there. I'm not worried that somebody is going to die from a fender bender. But a car rollover off the side of the road on a high speed interstate, that is a high mechanism of injury because there is likely going to be more injuries. That's just how we kind of use that phrase in EMS. It can also be, you know, suspicion of injury, something along those lines.
Okay,
Does that
thanks.
make more sense?
Yeah, that's good. Thank you.
Cool. When we were talking about life threats, I also heard someone say that respiratory distress. Absolutely, right? Breathing is one of those things we need to constantly do to stay alive. So if somebody is having trouble doing that one thing, that is something that could be a life threat. Yeah, keep going. What else could be a life-threatening injury or illness?
If they're conscious or not?
Sure, yes. So yeah, so I would say that if they're conscious or not doesn't necessarily tell us that they have a life-threatening injury, but it definitely tells us that they are sick. That's going to prompt us immediately to look into why they're unconscious. Could it be from a drug overdose, like I heard somebody say? Could it be from head trauma? Could they just be asleep, right? So level of consciousness is definitely one of those assessments that's going to help determine if we think that somebody is really sick. Doesn't necessarily indicate a life-threatening injury. A life-threatening injury, a drug overdose, an illness right there, that is something that we could fix depending on exactly what medication it is that they're overdosing on. Yeah, great job, guys. Another one here, cardiac arrest. So if somebody's unconscious, we're going to assess to see if they're in cardiac arrest, but that's definitely a life threat. So essentially, what we're trying to determine with our primary assessment is how sick is this person? Immediately when we lay eyes on them, okay, is there something that we need to fix right now? Can we stop the bleeding? Can we help them with their breathing? Or do we need to do any more assessments? So then after that, after we've regarded our patient, decided if they're immediate treatment or not, that's when we can kind of get into a more thorough assessment. So that's when we're going to look at our general impression of the patient, their level of consciousness. They're going to assess their airway, breathing, and circulation, and that's going to tell us the patient priority. So with our general impression, we're going to say, how do they look? So say that they're responsive, like this gentleman sitting in the chair. How would you say that he looks?
Fairly responsive.
Yeah, he looks responsive. His eyes are open. You can see him clutching his knees there. He's definitely conscious.
He looks like he's having a hard time breathing.
Yeah, no, exactly. He looks like he's having trouble breathing from how he's sitting, how his facial expression is. So that's a really good indication. Hey, general impression. Wow, he looks like he's having difficulty breathing. Wow, that patient looks like they're bleeding a lot, right? That's our general impression. That's what the first time we're laying eyes on our patient, what is it telling us about them? Level of consciousness, are they alert? So this guy would be alert. He's awake, his eyes are open. You know, if we say, hey, how you doing? And they look over towards us, that tells us that they're alert. What is the difference between these two things? What's the difference between alert and oriented?
Oriented would be more like, where are you? What day is it? What time is it? All that stuff. Alert is like they're responsive.
Yeah, for sure. So that oriented is, do they know what's going on? Do they know what's happening in the world around them? Do they know where they are? What time of day is it? Who they are? So there are plenty of people who can be alert, who can respond to verbal, and who can look at you and respond. But if you ask them a question about who they are, they might not be able to respond. So there is a difference there. And we're going to talk about how to assess that difference in a little bit. The next thing we're really going to worry about here is the airway. So is it open? Is there anything blocking it? Or are they able to breathe? So with this gentleman, his airway likely isn't compromised, right? It doesn't look like he's choking on anything. It doesn't look like his throat is swelling. He's having trouble breathing, which means he is having air going in and out of his airway. But, you know, it's something different. There's something else that's plaguing him. It's not an airway issue. It's a breathing issue. So really the first one is, are they breathing? If they're not breathing, that tells us they're sick. That tells us immediately we need to fix that. If they are breathing, how well are they breathing? This guy looks like he's having some trouble. Okay, so he is breathing, but it's an issue. So let's focus on that too. After that, we're going to move on to circulation, which is, do they have a pulse? Is his heart beating? Is their blood actually going through his body? Is it actually bringing oxygen to where it needs to be, right? That's a huge thing. That'll tell us a lot about our patient. And then all of this together tells us the patient priority. Are they sick or are they not sick? So this is what we can determine based on when we lay eyes on our patient. So what does your gut tell you from a general impression? What does it tell you about this patient? What did he call you for?
Hard time breathing, potentially.
Okay. Yeah, why do you say that?
Because he's on oxygen, and maybe something malfunctioned with his oxygen tank, or he's having some respiratory episode.
Okay, yeah, so he's on home oxygen, likely means that he needs oxygen frequently. I wouldn't say, though, that necessarily indicates he's having difficulty breathing. Look at his sunny disposition. This picture was taken when his granddaughter came in. He's just like, oh, hey, I'm happy to see you, right? So yeah, he's gone oxygen, but is there anything about how he's presenting that really tells us that he needs an ambulance, that he's sick, that something is going on?
Seems fairly chipper.
Yeah, no, if this guy called us, it's probably because he needs a lift assist. Oh man, I sat down, couldn't get up. Or, oh, I need an oxygen replacement. Oh, my tube is kinked. Could you get me a new one? Something like that, right? Now, what about this guy?
He's struggling.
Yeah, I mean, I don't know what he's struggling with, but he looks ill, right? What about him, from what we can see, tells you that he is ill?
He looks
Color.
It looks gray.
Yeah, yeah. You guys all said it. Jinx, all of you owe me a soda. He's great, right? He looks pale. It's not just somebody who has light colored skin, right? He looks worse than that. He looks like a sheet. What else about him?
His hair slick, maybe with sweat.
Yeah, he looks super sweaty to me. And one thing that one of a really great advanced EMT instructor taught me was that you can't fake being sweaty. You can get sweaty from not being sick, but you can't fake being sweaty and sick, right? So if somebody is sweating a lot and something is going on, they likely have something going on, right?
The way his
great.
mouth is open.
Sure, yeah, he looks like
Facial
a little bit
expressions.
beleaguered, fatigued, maybe having some difficulty breathing. Maybe he's complaining about something. He's telling you what's going on. Yeah. Anything else? I love where this is going.
His eyes,
What about him?
they seem spaced. He seems unfocused.
Okay. Yeah, I was gonna see if anyone noticed that his pupils look pretty dilated.
Yeah, it does not look like his eyes are tracking at all.
Yeah. Well, it's hard to just completely get that from a picture, but yeah, I would assume that they're not, right? Something is going on with him. He is sick. So that is a really good way. This general impression is going to be insanely important for us determining how quickly we need to treat our patient. We get called to the guy on the left. Okay, we can probably go a little bit easier into this. Let's ask him what's going on. Let's take our time. If this other guy, hey, I think he's sick, we can still ask him the questions we need to do, but let's do it a little bit quicker. Let's get him in the ambulance, start asking him the questions on the way to the hospital. Yeah, great job, guys. So after we get our general impression, we register how sick or not sick this patient is. We might have to do a little bit of more assessment, right? So we're gonna have to assess their level of consciousness. So we're gonna get to our first acronym here. Get ready, guys. There are a lot of acronyms in medicine. There are too many. The amount that I know that ABC, what that can mean, it's just endless, right? So just get ready. AVPU is a good one. And there are gonna be quite a few. Write them down. Work on memorizing them. It's not going to come immediately, but don't worry, we're going to drill them. You're going to figure them out. It's going to make sense in a little bit. So that level of consciousness, their orientation, are they alert? Are they oriented? We're going to start with their level of consciousness, right? So AVPU, are they alert? Are they alert to responsive? Are they responsive to verbal stimulus? Are they responsive to pain? Or are they unresponsive? So this is kind of a flow chart. We start with A, and we hope that we don't get to U. So that really means if somebody is alert, that means we walk on scene, we look at them. I'm looking at all you guys. I can tell that most of you are at least alert. I don't know about oriented, but you guys are here, right? I can see your eyes open. Some of you are smiling. Some of you are taking notes, right? You guys are alert. You're conscious. After that, I could say, hey. And if you guys look at me, hey, you're responsive to verbal, right? So if you just say, hey man, how's it going, to a patient, and they look at you and they say, it's not great, I just called 911. That tells me, wow, I can stop right here. They're alert to verbal stimulus. But say there's somebody laying on the ground, their eyes are closed, right? They're not alert. I walk up and I say, hey man, are you okay? And they don't open their eyes, they don't respond to me. Then I'm actually gonna have to cause them a minuscule amount of pain just to see if that'll wake them up. So I don't, when I say cause them pain, I don't mean walk up and slap them right across the face, although it's tempting. No, what we're gonna do is we have two approved methods. It's either gonna be a trapezius pinch. So what you wanna do with these fingers, and you're gonna find that trapezoid muscle. Oop, don't do that. And you're really gonna try to just touch your fingers underneath that muscle. I can't really show you a good one, but it hurts, right? So if you do that to yourself, okay, you squeeze, yeah, all right, it becomes uncomfortable. That muscle right there, this is also known as the Vulcan neck pinch. Doesn't make people pass out, it makes people wake up in EMS. The other approved method that we have is something called a sternal rub, a sternum rub. So if you take your knuckles right here, and you rub them really hard against the sternum, it hurts like a bee sting. It really hurts. So one of the things that we can do, if somebody is not responsive to our verbal stimulus, me saying, hey, are you okay? You can give them a quick sternal rub or a pinch on the shoulder. And if that wakes them up, if they say, oh man, wow, that was a really good nap, you're gonna be like, okay, good, that's a little bit better. But if you're causing them a good amount of pain and all they can muster is like a facial grimace or like a groan or like right, or they don't move at all, they don't react to it at all, that tells us, oh boy, they are unresponsive. That's bad, right? Has anyone ever been woken up really suddenly by just like a sharp pain or something like that? You just kind of wake up. If that doesn't happen and you're in a lot of pain, something is wrong, right? Something is going on where your body is not able to process what's happening. So this is a really good assessment for us to determine, oh boy, are they sick or are they not sick? If they're awake, they can hear us and they respond to us, great. If they can't and they don't respond to pain, or they do respond to pain, okay, they're probably a little bit sicker.
Kevin, I have another question. Sorry.
Shoot. Yeah, go ahead.
Oh, sorry, I dropped my unmute. When you say responsive to pain, so in that example, you give, your unconscious person a pinch, and you get like and then you stop pinching and you go back to nothing with no coming up to verbal. Are you counting that as P, responsive to pain, or U for unresponsive?
That would be responsive to pain. If there is any sort of response to that pain stimulus, that tells us that they're at least responsive to pain. If there's nothing at all, that tells us that they're just truly unresponsive.
Got it. Thanks.
So yeah, if we're trying to explain to a nurse or a doctor when we're giving our report what somebody's condition is, we would say, this patient called for chest pain, they're alert, oriented, versus called to a patient for an unknown medical, they were responsive to pain only, versus they were unresponsive. If we use those words, that will tell the doctors, oh boy, okay, they're at least responsive to pain. Responsive to pain is a better thing than being completely unresponsive. So we're hoping that they're going to be at least a little bit able to receive. Yeah, great question. So on to those ABCs. Here's that other acronym. This is also a very important one. So these three things are how we stay alive, right? At all moments, everyone who is alive has a working airway, they are breathing, and they have circulation going through their body. If one of those three things is interrupted, that person will likely die in the next couple of minutes. If somebody has an airway blockage, they're having an anaphylactic reaction, and the swelling causes their airway to close and completely block it, right? They will suffocate and they will die in the next couple of minutes. If somebody's eating a really good piece of steak and they're so excited that they swallow something too big and it gets lodged and there's no one around to help them and they can't get it cleared out, that person will die in the next couple of minutes because they're not able to breathe because there is an airway issue. Okay, if somebody is bleeding through an arterial bleed and they are losing pints and pints of blood really quickly, they will die in the next couple of minutes unless that bleeding is stopped. So these three things, those ABCs, are always what we're really going to focus on the first time we come in contact with our patient, right? This is going to tell us, are they going to die or are they going to be okay, right? If there's something that we can fix with one of these things, we're going to do it immediately, because if we don't, that person is worse off. So if there's ever an airway, breathing, or circulation issue, we're always going to fix it first as soon as we find that thing. And that kind of leads us to the idea of the golden hour in EMS. This really means if somebody is really sick, they pretty much have an hour from the moment that EMS gets there to get to the hospital. That's the golden hour. Anytime after that hour, their chances of survival really plummet. So what can that mean for us specifically in a state like Vermont?
Transport times and transport or time to scene from station.
Yeah, exactly, right? So depending on where you are, an incident happens, whatever it is. Between 2 and 5 minutes later, 911 is called. Between 2 and 5 minutes later, an ambulance is dispatched. And then depending on where you are, between 2 and 45 minutes is when an ambulance will get there. And then again, depending on where you are, 2 to an hour and a half to get to the appropriate hospital, right? So if somebody is really sick via ambulance, this might mean that we need something else. That might mean, hey, we need to get them to the hospital faster. We're in the middle of nowhere. Let's call a helicopter. If they need it, let's get it to them. If they're going to die in under an hour and it takes us 61 minutes to get to the hospital, we need to get them there faster. Okay, so that's really what it means for us. With this assessment, we're not also just checking for the presence of these things. So we're not just checking to make sure the airway is open. We're not just checking to make sure that they are breathing or have a pulse. We're also checking the quality of these things. So if somebody is breathing, what's the depth of their breathing? How fast is it? Do we think it's fast? Do we think it's slow? Do we think it's deep? Or is it shallow? Is it rough? Is it, wheezy? Do we hear noises that sound weird, right? It's not just, is it there? It's how is it, right? If somebody has a pulse, is it strong? Do I feel it bounding like against my fingers before even if I just like lightly touch them there? Or do I have to sit there and kind of think and feel like, is that it? Oh, no, is that it? Right? Is it weak? Is it regular? Does it beat at a constant rhythm like you'd expect a heartbeat to go? Or does it go something like this? Right? That's part of this assessment too, because that tells us quite a bit about our patient. It's not just enough to say, okay, are they there? It's going to tell us, okay, it's there, but it might not be in the next couple minutes, right? So that's that next part, presence and also quality. We don't have to sit there and take a full set of vital signs as soon as we arrive on scene. I'm not going to sit there and check for a minute how much their pulse is going on in my ABCs. I'm going to feel it for about 10 seconds. I'm going to say, it feels strong, feels regular. Okay, moving on to something else, right? That's also very important. And so like I've been saying, alluding to, and just saying out loud, the ABCs tell us the patient priority. And what we say here is, are they sick or are they not sick? It's kind of, a generalization if we break it down, right? But essentially what this means is somebody is sick, they need immediate care that we likely can't provide to them. They need doctors, they need the emergency room, they need surgery. We can't do that in the field. We get them to a place that can as soon as possible. If somebody's not sick, somebody stubs their toe, somebody calls for a bug bite on their butt, somebody calls for a nightmare, all of these things I have been called to, I would say, not sick, right? Or even somebody who has abdominal pain. They ate some wings last night. They're not sure if it's their gallbladder or if it's just the wings working through their abdomen, right? But it hurts so bad. I take all the vital signs, I don't find anything. I'd say they're not sick. We could take a leisurely ride up to the hospital. So that's really what we're trying to determine, sick or not sick. And that'll happen in the first couple of seconds when we start talking to our patient. With our scene size up, our general impression, our primary assessment, and our ABCs, those things are pretty much enough for us to determine, are they sick or are they not sick? Okay, so this is a very important part of our assessment. And after a while, it's just going to become second nature. You're going to walk on scene, you're going to say, sick. Let's do some stuff. Or, oh man, not sick. We can take it a little easy. Okay, any questions about this?
If you determine the patient is not sick and you're not going to transport and you have to fill out the 1093 form, you can refer them to like a walk-in clinic or their primary care physician, correct?
Oh yeah, absolutely. So sick, not sick doesn't necessarily mean that we're always going to transport them. It also just means we can find different avenues or more appropriate avenues of treatment, right? Okay, I don't think you want to go to the hospital. I don't think you need to go to the hospital. I would suggest that you go check out with your primary care, or hey, why don't you go to the urgent care right down the road? Something like that. Yeah, absolutely. We do not transport quite a few people. If somebody is conscious, alert, and oriented to a degree where we can say you are making your own decisions, yeah, even if they are relatively sick, sometimes we will cancel them. So everyone has their ability to make their own decisions about themselves unless they're not able to. Great question. Anything else? Cool. So now our secondary assessment. So this is when we're actually going to get a little bit more detailed, and our secondary assessment usually is just kind of a little bit more robust. This isn't really a quick one. This is our focused assessment. So our ABCs, our general impression, have all told us what the issue is, but our secondary assessment is going to be us delving into that issue. So if somebody says, I have chest pain, we check their ABCs, they're breathing, they've got a pulse, and their airway's fine. They're sitting in a chair, looking at me, they're alert. Okay, chest pain, scary. I'm going to say that this is a high priority patient, but let's do a little bit more assessment. Hey, does it hurt when I palpate on your chest? You say that you've got some pain right here. Does it increase in pain when I palpate it? Let's listen to your lung sounds. Do I hear air going in and out of your lungs okay, right? Hey, maybe we take an EKG. Let's put on the monitor, see what it says about your heart. That's what we're going to consider a secondary assessment, really a focused assessment on what their chief complaint is. So whatever the issue is, now we're going to focus on it. We're going to get in there and we're actually going to worry about figuring out what's going on versus just determining this overarching level of sick versus not sick. So our level of secondary assessment is really going to depend on what the patient is complaining of. If they broke their toe, we really only have to assess their toe. Yeah, I heard a voice.
So the primary assessment, let's say they're really sick. So we treat like say they're bleeding, we treat the bleeding,
yep,
get them into an ambulance for transport. Would we do the secondary assessment in the ambulance?
Yeah, sure.
Like on during
that
transport?
works fine with me. You fixed the life threat. They're still in danger, right? They lost a lot of blood. We've put on a tourniquet, but they need surgery. Our secondary assessment would be looking at the wound that caused them to bleed. Hey, okay, can we wrap this up a little bit? Can we do an assessment of it? They bled a lot. Let's focus on taking their blood pressure, make sure that they still have enough blood pressure. Do they need fluid, right? So our secondary assessment is going to help us determine some other treatment. But yeah, we can do it whenever, essentially. After we've fixed those life threats, those are the most important things. And then our secondary is just kind of once we're, okay, they're not going to die, let's go and check out a little bit more specifically on what's going on. That makes sense, Connor? Okay. So an assessment for significant trauma is going to be a little bit different, right? We're not going to spend the time to really try to wake them up. We're going to do our assessment of, are they alert? Are they alert to verbal, pain, or unresponsive? We're going to do our ABCs, and then we're going to do what we call a rapid head-to-toe assessment. We're going to go through, we're going to try to find all of their injuries in a quick amount of time, figure out which ones we need to fix right then, and then also figure out what
I think we lost him. So now we actually want to take a break anyway. So now's a good time for you all to take a break. So I'm going to pause.
Cool.
Okay, can still see my screen and everything?
Yes.
Yep, great. Cool, too far. Okay. So like I was saying, significant trauma is gonna spawn us to do a much different assessment than if we were managing somebody with chest pain. These people typically need a lot of hands-on assessment. If somebody has hidden injuries or broken bones, right, and they're unconscious, they're not going to be able to tell us specifically where those injuries are. They're not going to be able to tell us really what's going on, especially if they're just responsive to pain. We're going to have to do a lot of assessing ourselves. So like you can see in this picture, sometimes that means we're going to have to remove their clothing. We're going to have to cut it off or to get a better look at what's going on. Especially when we're talking about those airway, breathing, and circulation threats, if somebody has an injury to their torso, to their ribs that is impeding their ability to breathe, we're going to have to get our eyes on it. We're going to have to see what's going on. Is there something that we can do to fix it? Can we apply a dressing that stops air from entering the chest if it's an open hole? Is there just too many broken ribs? Do we have to provide ventilations with a mask, with a bag valve mask? Do we have to actually breathe for them versus what's happening in this picture where this guy, he's just got a mask of oxygen on his face. He doesn't need to be breathed for, but he still needs some oxygen, right? We're also going to put an emphasis on assessing vital signs, especially on significant trauma. We want to know what's going on inside their body as well. And all of the time when we're assessing vital signs, we're recording them and looking for trends. Are they trending up? Are the numbers increasing? Are some numbers increasing? Is the pulse slowing down? Is the blood pressure going up? Is the blood pressure going down, or is the pulse going up? We're going to be looking for those trends. So assessing those vital signs is very important. The other thing is the patient history. Do they have a history that might help us understand what's going on? Whether that's somebody lost consciousness at the top of a ladder and then fell, they have some bleeding from their leg, but we also find out they have a history of heart issues, and on our assessment, we determine that they're in cardiac arrest, right? That could help us determine what's going on. However, if somebody's unconscious and there's nobody around who really knows a lot about that person, getting a patient history in significant trauma sometimes doesn't happen, but we still want to make sure that we're thinking about that and trying to get it done. The main things with a trauma assessment for significant trauma is this head-to-toe assessment. And trust me, by the end of class, you're going to be very familiar with this. This is one of those skills we're really going to hone into you. Because for the NREMT test, they give you 10 minutes to do a head-to-toe assessment on a significant trauma patient. And in the field, we try to get it done in under 2. So we are going to practice it a lot so that you can do it in your sleep. Now, with that more detailed trauma assessment, that head-to-toe, this is another acronym that we're looking for, DCAP BTLS. And that just stands for all the different kinds of injuries that we're really going to be looking for. So deformities. Is somebody's arm obviously broken, right? Is there an obvious deformity? Does it go at an angle? Is the finger broken? Does the body look misshapen? Is there something obviously broken, right? We're going to be looking for contusions, pretty much bruises, abrasions, where the skin is kind of scraped off due to friction, puncture wounds, so whether that's a stabbing, whether that's a shooting, whether that's an unintentional impalement, whatever it is. Burns, so were they burned by thermal heat? Were they burned by steam? Were they burned by electricity? Were they burned by a chemical? Something along those lines. Tenderness is really just, do they react to pain or report pain when you touch it? So I'm sure that all of you have been injured to the point at some, like in one point in your life, to the point where you said, ow, that's pretty tender, right? Ooh, you touch it, ooh, that's tender. That's pretty much what we're looking for. A laceration stands really for just when somebody is sliced, when the skin is cut. So laceration is the fancy word for a cut. And then swelling, are we looking, does any of their limbs look enlarged, right? Does it look like it's swollen? Does it look stiff? Does it look bigger than the other one on the other side? So DCAP BTLS, that's another one of those acronyms. Don't worry about it. They're going to be a lot. You'll have time. It'll click. But that one is the one that we use when we're talking about trauma and what we're looking for really when we do those trauma assessments. So that head to toe, do they have an injury? Which version of the injury is it? And we do that by inspecting, palpating, and auscultating. So inspection, really just looking with your peepers, looking at what's going on. Hey, I'm looking at you. Do I see an injury? Palpation is when we actually physically touch our patient. Anytime we take our hands and we press on an area of somebody's body to determine, to elicit pain or to do a little bit more of an assessment. And then auscultation is the medical term for listening to something. So for us, that means using a stethoscope and listening to their lungs, maybe listening to their stomach, see if we can hear any air going into there or something along those lines. Those are really our best 3 tools, our best 3 ways of assessing for these types of injuries. So we can look, we can feel, and we can listen. Now, we are going to touch on the Glasgow Coma Scale. It is relatively complex and hard to get down. It's also one of those things where it's brought up quite a bit, but we don't actually tend to use this a whole lot in practice. What the Glasgow Coma Scale is aimed to do is to give a really quick identifying number of how sick a patient is and why. So the way that we calculate this is that we look at their ability to open their eyes. So if it's spontaneous, they do it all on their own, right, without having to prompt them, they get a 4. If they look at us when we say, hey, what's going on? Do you know where you are? What time of day is it? They get a 5 if they're oriented. So 4 plus 5, that's 9. And then say they have a good motor response where they can obey our commands. I say, raise your right hand, and they raise the right hand. that is a 6 right there. So the total would be 15. That is a totally normal person, not suffering from anything really that is affecting their ability to respond. Now, if they don't open their eyes, they don't look at us when we have a verbal response, and they cannot follow commands or have a motor response, they get a 3. That is the lowest you can go. A 3 is really bad. What we tend to say about the Glasgow Coma Scale is that if they have an 8 or lower, they're really sick. And the closer they get to that 8, the closer they are to being sick. However, this is one of those things that can be misleading sometimes, right? So it's just one of those things. If you say, hey, they have a Glasgow Coma Scale of 7, right? That could mean a bunch of different things. That could mean that their eyes open spontaneously, they have incomprehensible words, and they have no motor response. Or it could mean any other sort of form. So it does have its drawbacks. However, it is pretty useful if you wanted to briefly describe to somebody how sick somebody is. So we do use this, but it's not one of those things that is super pounded into EMT heads anymore. This used to be one of the main ways that we communicated to higher level providers. It's not so much anymore. And we really use this, especially when people are really sick. So if a hospital asks you to calculate a GCS or a Glasgow Coma Scale, it means that they're concerned and they really want to know what's going on with this patient. Any other time, if you're giving them a good report of what's going on, they could be able to calculate this on their own. It's very rare that somebody's going to be like, get me a Glasgow Coma Scale before you get here. They're more so going to register how sick that patient is from your report. So it's beneficial to make sure your reports are good too. When we talk about simple trauma, so not multi-system, not major, somebody has a local injury or localized injury, and that's the only injury they have, we're really going to stick to our focused assessment. So like this guy in the picture, right? It looks like he has broken his arm. We can see that major deformity. We can also see some of the bruising, those contusions. And if it was a little bit later on in the day, I bet we'd be able to see some swelling in that area too, right? So he's got signs from the DCAT BTLS, but if it's only that arm, we're not really going to have to worry about, okay, is he going to die in the next couple of minutes? If it's a simple fracture like this, we can say, okay, let's do a focused assessment. Let's focus solely on that broken arm. I'm not going to do a complete head to toe, go from the top of your head to the bottom of your toes, looking for injuries. I know you've got the broken arm. You're complaining about the broken arm. Let's take care of that broken arm, right? So we'll do a focused assessment. We're going to try to keep it nice and stable. We just really want to try to make sure it doesn't get any worse, because that way that would be on us if it did get worse. So we're going to really focus on that one spot, take vital signs, get a patient history, splint that injury, and then bring them to the hospital. It's going to be a little bit different of a call than somebody who has a lot of different injuries, who's only responsive to pain and has a life-threatening thing that we need to fix, right? So it's a little bit different, but we're still using those same properties of our focused and primary assessments. Now, when we talk about that patient history, right? I've said it a couple times here in a little bit with the trauma looking for patient history and then simple trauma looking for patient history. Now we're actually going to start talking about what that means. So these next two acronyms, SAMPLE and OPQRST, we'll get there, is solely about determining patient history of their entire medical history, and then also what's happening today. What is this medical event happening? So SAMPLE is about their entire life, except for one of the letters. For the most part, it's about what has happened in their medical history that's led them here. What do we need to be concerned about? And then when we talk about OPQRST, that's going to be talking about what's happening right now. So SAMPLE stands for signs and symptoms. And this is that one letter that doesn't really, or I mean, it's talking about the direct moment right now and how it relates to their previous history. So what are they experiencing right now? Are they having chest pain? Are they having difficulty breathing? Are they altered? Are they unresponsive, right? So what is happening with the patient? What are the signs? What are the symptoms? The next one is A for allergies. What is this patient allergic to? Now, sometimes you're going to get a patient who hands you a literal novel full of things that they're allergic to and medications that they take. Other people are just going to be like nothing and nothing, right? It completely depends on the patient. So allergies, are you having an allergic reaction You are because you're allergic to shellfish and you ate shellfish? Oh, hey, well, look, that's very important to our assessment. Anything else? We're going to figure out why, besides, like food allergies, is determining if somebody is allergic to something very important for people in medicine.
You don't want to give them a medication they could be allergic to, or anything else that could possibly be in a medication.
Yeah, absolutely, right? Somebody say they need aspirin. They're having some chest pain, and you're like, you're having chest pain. I know that you need this medication here. I'm a competent EMT. You take these 4 pills, chew them up, swallow them. Great. Let's get into your medical history. Hey, are you allergic to anything? Yeah, aspirin. Right? And you're like, oh, well, you just ate a bunch of aspirin. So now we got to really go to the hospital, right? So these questions are incredibly important before we start really giving our patient anything, and it's just going to help us. So we always want to ask allergies. We always want to ask if they take any medications, right? Similar to the allergies, we want to really be cautious and ask our patient about their medications really in depth too, because there are some medications that we as basic EMTs can give to people which really poorly interact with other medications. I'm talking about nitroglycerin. And if somebody's taking another blood pressure medication and they take a dose of nitro, they have the chance to have their blood pressure really tank, drop down to the point where they don't have a pulse anymore. So we really want to make sure that we do a good, thorough history, assessing what their allergies are and if they take any other medications. Now, the PLE part of sample is about their pertinent past medical history. So somebody having chest pain, has this happened to you before? Yes, you have had a heart attack and they placed a stent in your heart. Wow, that is pretty pertinent to this chest pain that you're having. Versus somebody who has chest pain and you say, do you have any history? And they say, yeah, I broke my toe. I had mono in 7th grade. I once sneezed at a Nickelback concert, right? Like if you asked random things like that, they're going to give you their whole medical history. The P stands for pertinent past history. You're having chest pain. Has this happened before? You're having difficulty breathing and you have a history of COPD and CHF. Wow. Okay, it seems like this has happened before. From there, we're also going to worry about last oral intake. One thing that I kind of like to add to this is it's not just last oral intake, it's last ins and outs. So last time somebody ate something, and then last time somebody had a normal bowel movement, anything like that. So, hey, you've been drinking a gallon of water a day, but you haven't peed in 4? Oh boy, that seems kind of rough, right? Or somebody's having really bad abdominal pain and you ask their last oral intake and they say, yeah, like 6 pizzas. It's going to give us a little bit of a determination of what's going on versus somebody who hasn't eaten anything and hasn't put out anything in days or weeks.
How
And then
important? How important is it knowing the last time a patient has taken a medication? Because if their blood pressure is tanking, it could be due to not taking a blood pressure medication. Is that important to know at this time?
Yeah, so I would include that in your medications. So when you ask them, hey, do you take any medications? And they say, yeah, a whole bunch. And you say, have you taken your normal ones today? You can add that in there as well. If somebody doesn't take medications, then you're not going to have to worry about it unless you want to ask social history, like, drugs and alcohol, that kind of stuff. But yeah, asking when the last time they took their normal meds is very important.
Okay, cool.
Yep. So then finally, when we get to the E of sample, we've got events leading to the injury or illness. What happened right before you called us? What led you to call 911? What is bringing you to this point, right? And that's pretty much it. What happened before could really be anything. So that's just going to help us determine what's going on. Any questions about sample? Cool. Now the next one, less easy to remember because it's not a word, right? It's just an acronym, OPQRST. So sample, it's about that history, what happened before. And this is really kind of about, okay, what's happening now? What's going on with why you called us today? So O stands for onset. So that's kind of similar to the E, right? Events leading up. When did this start? What were you doing when it started? What changed? You were fine, and then something happened where you're not. What was that moment? After that, we've got P, which stands for two things. Stands for provocation or palliation. So provocation is kind of along the lines of onset. Onset is kind of like what happened to make it happen, what's going on. Provocation's like, okay, were you doing something that made it happen, right? If somebody's experiencing chest pain and they said, well, yeah, I was just running a marathon. Like, okay, that's a pretty good provocation versus somebody who's having crushing chest pain and was sitting there watching TV, right? There's a little bit of a difference there. And then palliation is like, is there anything that you can do to make it better? You're having chest pain? Is there anything that you do to make it better? Has this happened to you before? You take nitroglycerin? Did you take it today? Does that usually make it better? You're having difficulty breathing. Is there anything that makes it better? Do you take an inhaler? Does sitting forward in that position help you? Does laying back help you, right? That's what we're looking for with palliation. I think I actually didn't. I did put these in. So then quality is, what does it feel like? If it's pain, okay, just describe the pain, right? Put out some different descriptions for pain.
Stabbing.
Sure, stabbing, right? What else?
Numb.
Throbbing.
Okay, throbbing.
Dull.
Dull.
Pressure.
Pressure, yep.
Burning.
Burning, yeah. Any type of pain, anything that makes you feel uncomfortable can be said here. Now, one of the things I want to emphasize about this question is if I said, hey, does that pain in your chest, does it feel stabbing or does it feel crushing? What have I forced my patient to do?
Think about it in those terms.
Yeah, I have forced them to choose between stabbing and crushing. And as you guys just demonstrated, there is an endless amount of describing words to describe pain. So when we're asking questions like this, quality, it's not, is it this or is it that? We always want to leave it open-ended, is what does that pain feel like? That's it. And then that person who is experiencing that pain is the best person to listen to when they tell you what it feels like. So, and also this can really make a difference for what's going on with our patient. If I went to a patient with severe back pain and they said, oh, it's stabbing and it's aching and it's kind of dull and it's just like really stiff, versus it's tearing and it hurts a lot, it's really bad, I feel like I'm being ripped apart. That gives me two different ideas of what's going on from this patient. Somebody said that it's like a stabbing pain and it's kind of just like hurts and it's stiff. I'm going to think there's a musculoskeletal thing going on. They hurt themselves. They lifted weights wrong the next day, the previous day or something like that. But if they said it's tearing in my back and it hurts a lot, the first thing that comes to my mind is an aneurysm of the descending aorta. That is a very common phrase that people use with that injury, and they say it's tearing. And there's not a lot of other situations where people use that description, and it's usually unprompted by us. So this can also be a really important question. Now, along the lines of the sensations that they're feeling, specifically this pain, another word that we can ask them is radiation. Does it move anywhere else in your body? There is a difference, again, in determining a condition that somebody is feeling. If they say, I'm having chest pain and, oh, it's crushing and it moves up my arm and into my left side of my jaw and it kind of goes down my arm, right? Versus, oh, I'm having stabbing pain that's right here. It doesn't move anywhere else. It just feels like it's right there, right? That can tell us different things about what's going on. So radiation, does that pain move anywhere? Or is it staying put? That's pretty much it. Severity, pretty straightforward. How bad, right? On a scale of 1 to 10, how bad is your pain? 1, you're frolicking in a field. 10, you're rolling on the ground, writhing in pain, expecting you're going to die, right? And if someone says 11, they're lying because they clearly didn't listen to you. 1 to 10. Okay. Pet peeve there. Finally, we've got time, similar to like onset and stuff like that, but particularly, okay, how long has this been going on for? Maybe that chest pain, that really bad chest pain started today, around half an hour ago, but they've been feeling kind of off for the past couple of days, right? Something else has been going on. So time is pretty important, especially if we're talking about like a stroke patient or something like that. Time would indicate how long they've been stroking out for. It can indicate how close they are to a really bad incident. So time is also very important. Okay, any questions about sample or OPQ-RST? These are, Sorry, go ahead. I know I just said ask questions and start talking again.
For severity, do you ask what's your 10?
Yeah, you could, right? If you ask somebody, hey, on a scale of 1 to 10, how bad is this pain? And they're like, well, you know, I've been around the block. I got a really high pain tolerance. So like your 10, it's probably like my 4. Yeah, you can ask them that. You'd be like, okay, so you're at a 10. Okay, yeah, you can figure it out from there. Sure, ask them. Really what we're looking for is it bad or is it not that bad?
So I have a question.
Yeah, go ahead.
And the radiation, if it moves anywhere, let's say it does, or it's static, what are you going to change in your line of thinking if it, let's say it's dynamic?
Sure, great question. So I'll go back to that example I was using. So crushing chest pain that radiates down the left arm.
Yeah,
that's pretty indicative of like a cardiac event, somebody having a heart attack, right? So crushing and radiation down the left side or up into the jaw is really classic heart condition symptoms, where somebody having chest pain on the right side of their heart that feels like it's not moving anywhere and it's just super pinpoint and it feels like there's a knife right here is more likely along the lines of a pulmonary embolism. So that little assessment right there could tell me if I'm worried about a respiratory issue or I'm worried about a cardiac issue. So there are plenty of times where, you know, the radiation might be like, oh, I'm having some abdominal pain and it kind of moves every so often, right? It's not going to give us a lot of really detailed information, but it will when it counts. Somebody having chest pain and they tell me, no, it doesn't move anywhere. It's just right here. I'm thinking, okay, you're having a pulmonary embolism. We need to get you oxygen into the hospital really quickly. Versus crushing and radiating, I'm like, you're having a heart attack. We need to get you aspirin, nitro, ALS, and get you to the hospital really fast. Yeah, and we're going to talk about how to figure out which conditions are which as we go along. It's gonna come. Yeah, great question though.
Fair enough. Thank you.
Sure. So sample and OPQRST, these are the bread and butter of talking assessments with our patients. These are the questions that we're going to ask pretty much everybody. There are going to be times where we're not really going to be able to ask some of these questions. So say if somebody's having difficulty breathing, we're not going to be like, does it move anywhere? Right? It's not going to do that. But if they're having pain, we can say, what's the quality? What does it feel like? Does it feel like, you know, like, are you short of breath? Or are you having difficulty breathing? Can you get air in, or is it tough to do that? You know, we can ask questions along those lines. Now, you're going to get to a point where this just makes sense. This is the natural line of questioning when it comes to figuring out what's going on with somebody. It's like, the way that I think about it is, anytime someone calls me and I talk to them as a provider, they're my patient and I'm trying to figure out what's going on. This is just kind of how it goes, right? Hey, my name's Kevin. What's your name? What's going on today? You're having chest pain? Oh my gosh, wow. When did that start? Did you do anything? What were you doing when it started? Did anything happen that made it go along? No? Okay. What does it feel like? Can you tell me? Can you describe it? Okay, it kind of feels crushing. Oh, that doesn't sound fun. Does it move anywhere in your body? Right? Does it go anywhere else? No? Okay. So how bad is it, would you say? Would you say it's really bad? 1 out of 10 scale, right? And then how long has it been going on for, right? It's just kind of how our curious nature and trying to figure out what's happening with this person is just naturally how it goes. And we can say, okay, you're having chest pain, it's crushing. Those are your signs and symptoms. Right? Okay, do you have any allergies? Nothing to cause chest pain? You take medications for chest pain? Okay, has this happened to you before? Did you eat anything today? And then what were you doing, right? So all of this is really important. And all of this comes naturally. And it will take some practice, remembering, you know, what we want to know, and then also taking that information and recognizing what it means. But it'll come naturally, and it's just part of the medical conversations that we're going to have with our patients. It's really what all of our assessments are. It's just a conversation with somebody who's hurting, and they kind of want to, they're looking for us for help, and we just want to know what's going on.
Can I ask a quick question?
Absolutely.
It seems like the two overlap one another, right? And so I noticed that you were going through like the second group, but then you went back to the first group. So is there a standardized form where you go through all those same questions, but it's only one list? Because again, it seems like it's kind of contradicts, like repetitive if you go through both.
Yeah, so I mean, what I'd say is all of the questions are important. And you can use, if you ask OPQRST before you ask sample, there are some things that you can just omit, right? But there are going to be times where we're only going to ask sample, and there are going to be some times where we might only ask OPQRST. So they are separate because they're meant for different things, but we tend to ask everyone both. So there is some overlap, and it is a little bit kind of annoying, but for the most part, we're considering sample being like, okay, what is your history of, like, what's your medical history? And then we're considering OPQRST, what's going on right now. So there is a little bit of that line there, but yeah, there isn't one standard thing, but you can absolutely transfer whatever you want.
Okay, thanks.
Yep. Okay. So when is each assessment necessary? Right, so if we've got an alert medical patient, they're conscious, and they are telling you that they're complaining of this issue, right? So I'm having difficulty breathing, or I am having chest pain, or my leg really hurts, right? That's the ideal patient. That's someone who we can talk to. That's someone who we can really delve into their issue with. We ask them their OPQRST. When did that leg pain start? What started it? What does it feel like? Does it radiate? How bad is it? We can take their vital signs. We can ask about their medical history. And then we'll do a little bit more of that physical assessment. Say their leg is hurting. Okay, let's palpate the leg. Let's see if anything else is going on. Let's do a little bit more of a focused assessment. Maybe you warrant a head to toe. So for alert medical patients, we're going to do a lot more talking. We are going to do quite a bit of assessment. Depending on what the situation is, will determine what we actually assess for. But with an alert patient, majority of the time, the biggest thing that we're able to help out with is something that we call PFA, psychological first aid. So majority of the time, we're going to be talking to our patients, and that's what's going to help. Really asking them questions, being a kind person, being a genuine provider is really what's going to help them in a lot of situations. You know, we're not doctors. We are not in an ambulance that has unlimited resources. We can't perform surgery, right? We honestly, we can't do that much. But what we can do is we can make that person more comfortable, and we can really show them that we care about them. So PFA, talking to our patient, that's really what's going to happen a lot if they're alert. But we're also going to want to make sure that we're getting to the bottom of what's going on. Now, if somebody is unresponsive, maybe not due to trauma, we don't see any reason for them to be unconscious. They're in their house. There's no blood. There's no mechanism or suspicion of injury that could tell us that why they're unconscious, right? We will do a rapid head-to-toe assessment because we didn't expose this guy's chest. We might not be able to determine why he's unresponsive, right? It looks like he got a big old cardiac scar. Oh boy, maybe he's unresponsive due to cardiac issue, right? So that is a time where a medical patient will need a head-to-toe, more focused, full-body assessment. Because one, they're unconscious, they're not going to be able to tell us what their complaint is, and we might be able to figure it out. Somebody's unresponsive, we do a head-to-toe assessment, we find an insulin pump. Somebody's unresponsive, we do a head-to-toe assessment, we find indications that they're overdosing on opiates. Medical issues that they're not able to tell us about, but we were able to kind of determine based off of more of a trauma skill, right? Like something physical, hands-on. So our assessments go both ways. Trauma, we're going to want to get our hands on. And then certainly with medical patients who can't tell us what's going on, we are going to have to do that really in-depth head-to-toe. Of course, vital signs are incredibly important, especially if someone is unresponsive, especially with after our ABCs are determined. And then if somebody's really unresponsive, we're going to try to get the patient history from somebody who knows them. So this guy likely has somebody at home with him. If somebody called and we find him, right, somebody likely knows about what's going on. So we can ask family members, we can ask children, we can ask really good friends who are on scene. Hey, do you know anything about their medical history? Do they take medications, right? Do they have allergies? Do they have any pertinent medical history that can tell us why they're in this situation? So the patient history doesn't necessarily have to come from them. We just want to try to get it because it can help us determine what's going on.
If you have a patient that's home alone and you come up upon them and they're unresponsive, you could always probably look in their medicine cabinet, couldn't you, for what they might be on?
Yeah, absolutely. Like I said, we are medical detectives. If somebody calls, if we just find somebody in a true medical emergency and we need to figure out what's going on and we think that there is a medication involved, absolutely, I'm going to send my fourth to go look through their medicine cabinet, find something, right? I'm also going to say, hey, if this person's in cardiac arrest, go check their fridge for a DNR or some, it's like, yeah, absolutely, investigate, look in their pockets, you know, do anything that you can to help you figure out what's going on. As long as you're doing it with the intent of helping your patient, it's totally fine.
And there's no legal or privacy concerns when it comes to that?
So, I mean, there can be concerns, but it's totally within our realm to do that. What we'd be concerned about is if an EMT is abusing that. So, you know, we go through the whole process of when you become an EMT, you get background checked. You know, you're asked to disclose all your, if you have any federal crimes, stuff like that. They ask you those questions, and you will be subject to, you know, punishment if you do break that trust. But we are really trying to help somebody stay alive. And so there are some times where we're going to do things that kind of look a little like, hey, we're rummaging through their stuff. We're looking for something. I am rummaging through an unresponsive person's pockets to see if they have a medical like tag, to see if I can get a name for them off their ID or something like that. Yeah. So it's just up to us to be trustworthy. Cool. Any questions? I just talked a lot about some complex things. Again, don't get overwhelmed by the amount of acronyms. It starts to just become natural. Great, here's some more information then. Vital signs. So these vital signs right here are what we pretty much consider to be the vital signs. And when I say vital signs, I mean that they're vital, right? So people need these to survive, and us measuring these levels can help us determine what's going on. So the main ones that we worry about is pulse, and respiration, and blood pressure. So those three are really kind of the meat and potatoes. So we're going to count their pulse, we're going to count their respirations, we're going to note the quality of those two things, and then we're also going to assess their blood pressure. Now, the one underneath that, the pulse oximetry, right here, this is what this little device is on this person's finger. So it measures the amount of hemoglobin bound with oxygen. We'll get into this a little bit more when we actually talk about respiratory stuff. For all intents and purposes, what this does is, with magic, measures the amount of oxygen in this person's blood. I don't know how to describe it besides that. It's all magic. It's some sort of light. Anything after that, I don't know. It gives me a number, tells me good or bad. So this just really helps us determine if a patient has enough oxygen in their body. Are they breathing okay? Is there a respiratory issue or is there a ventilatory issue? This can also tell us that it's not working well, right? So if we put an SpO2 on somebody who's just come out of a burning building, it's actually going to read 100%, even though they're covered in smoke and soot and they're breathing really heavily, because it's measuring the amount of seats on the hemoglobin bound, not the amount of oxygen. So it's a really good assessment tool. It has its limits, but it's really helpful if we're just trying to get a good idea of how well somebody is breathing. Other vital signs here, pupils. So when we were talking about that sweaty guy in the quick general impression assessment, we noted that his pupils seemed a little bit wide, a little bit dilated. So there are plenty of things that a pupil assessment can tell us. They are really just the window to the brain. People say that pupils are the window to the soul, and they're not actually that wrong. They're really just the window to the brain. How the pupils respond, how they look, how they react can really tell us what's going on with the brain. I used to work at a place in Colorado that had this device. You put it on somebody's head who's suffering from a concussion, post-concussion, anything like that, and you do versions of eye tests, and it measures how well your eyes respond to the millisecond based off of your pupils, and it can actually pinpoint areas of your brain that is affected. So we don't do that level of assessment, but with a pen light and looking in someone's eyes, seeing how quickly and how evenly those pupils respond to light can really tell us a lot. It can tell us, are they alive? Are they on stimulants? Are they on depressants? Are they on opiates? Do they have a head injury? Are they having a stroke? It can tell us a whole bunch of different things. So pupil area assessment, really important. And then finally, we talked about this again in that general impression. The skin is an incredibly good assessment tool to use. It is the biggest organ in our body. It is considered an organ, our skin. It's the biggest one in our body, and it's incredibly responsive to how we are doing internally. As you guys can probably see, I am standing, I am talking, it's hot in my room, so I am flushed, right? My skin is showing you that I have some pretty good circulation going on right now, right? But if I was sick, I'd probably be pale and sweaty, and I'd look like a sheet, right? So a quick glimpse at somebody's skin can tell us what's going on. Do they have a blue? Yep, go ahead.
Sorry, one of the questions that was just asked by somebody else is, can you tell the kind of drug a person is on by their pupil?
Sometimes, yeah. You can't say for sure. Like if I looked at someone's pupils, I couldn't say, oh, they're on this strand of LSD. But if somebody has really blown out pupils, it leads me to believe they're either on a hallucinogen or a stimulant. If somebody has really sluggish pupils, but they're normal size, they're likely on a benzodiazepine or on alcohol. They're on a downer. And if their pupils are really, really constricted, it tells me they're on an opiate. So there is a level that we can determine, but it's pretty impossible to say, oh, based off of this millimeter that their eyes are, they're on this specific drug. There are just a couple different drugs that really show us what's going on. Great question. So with that skin assessment too, we're going to be looking for things called cyanosis, so blue tinge around the lips or on the gums, in the nail beds. If it's blue on my fingertips, that tells us that we're not breathing well. If I have like a pasty yellowish tinge to my skin, it's called jaundice. It can tell me that something is wrong with one of my internal organs. If I'm really just pale, if I'm really red and flushed, all of those things can really help determine what's going on. And now there are going to be a little bit of different kind of assessments that we're going to have to make depending on the person's, level of pigment in their skin, right? For me, it's pretty easy to tell what my circulation is like. And you could see from my nail beds, because I'm a lighter color, I'm going to show up blue a little bit easier. But somebody who has darker skin, we might have to take a little bit closer of a look, like in their gums or in their nail beds. We're really going to have to look a little bit harder. So it all acts the same way. We will be able to make the same assessments, but we are going to have to change a little bit depending on the level of pigment in that person's skin. So now I do have a really important question. Why are baseline vital signs so important? And what I mean by baseline is when we show up, the first set of vital signs that we take. So the first time we come in contact with a patient, we take all of these vital signs. Why is it important to take that first set?
It gives you the
see if they're
can
doing
tell you
better.
whether your patient's doing better or worse from the time you initially get to them.
Yeah, right. So I heard people say it tells us where they're at, tells us where they're at right then. But then why that is important is because we're not going to just take one set of vital signs, right? We're going to take vital signs at least every 10 minutes. If they're really sick, we'll probably bump that up and take vital signs every 5 minutes. And then after 15 minutes, right, with 3 sets of vital signs at least, we're going to be able to see that trend I was talking about. So is their blood pressure going down? Is their pulse rate going up? How are they breathing? Vice versa. It's really going to give us an idea of how somebody is doing. We're looking for trends. We're looking to see if they're doing better or if they're doing worse. Great job, guys. So, counting the respirations. Like I said before, it's not just enough to say how many times a minute are they breathing, but we're also looking at the quality, the rhythm, effort, listening to them, how do they sound, and then the depth, right? So normal respirations for an adult is between 12 and 20 breaths per minute. For kids, it's faster. And then for infants, it's even faster. That's pretty much a rule of thumb for vital sign ranges, is that the older you get, the less you need just to be baseline, to be average. The younger you are, the more times you need to breathe, the more times your heart will beat. Now, another kind of frustrating thing is you can look up like infant ranges for vital signs all you want, and you'll probably find no source that has the exact same thing as the other. Just keep that in mind. When you get younger, it gets faster. The younger you are, the higher it should be.
Is there a point as an adult that number starts to, like, as you hit a certain age, doesn't it start to go the other direction again for senior citizens?
Not necessarily, no.
Okay.
That really kind of depends on medical conditions. So once you hit full grown adult, 17, 18, like when we're talking about physiologically an adult, that's when it should be around 12 to 20 breaths per minute. Now it does vary, if you're relaxed and you're sitting down, you're kind of zoning out watching TV or something, I bet you've breathed like 9 breaths per minute. It's happened to all of us. But for the most part, a healthy adult will breathe somewhere between 12 and 20 times a minute. And so if we're counting the respirations and we see, wow, they're breathing at around 8 times per minute, it looks pretty irregular. It's not a normal rhythm. It looks pretty labored and it's shallow with some snoring. Oh boy, this person is sick. They will die if we don't help. Versus they're breathing 20 times a minute. I don't hear any irregular noises. It looks like it's a regular rhythm. It looks totally fine. They're healthy, right? However, there can be a difference there. Say someone's breathing 12 times a minute, super labored with wheezing and snoring, and it's shallow. Even though they've hit that 12 time a minute mark to be normal, the other assessments about that breathing tell us that it's not good breathing. It might be a normal rate, but the rate doesn't equal quality. Okay, so that's why that's so important. We want to make sure they're breathing well enough to survive. If they aren't, we can help them out a little bit. I'll leave this up so you guys can just note it if you haven't already. Cool. So the pulse, pretty simple. You're going to palpate the pulse and you're going to count it. How many beats are in 30 seconds? And then you're going to multiply that by 2. I know there's some math, but if I can do it, you guys can too. Trust me. So number of beats in 30 seconds times 2.
So I have a question.
Yeah.
So I've been taught for respirations to do 15 by 4, and same with pulse, 15 by 4. Is that still going to be accurate?
Yes, less so. The shorter amount of time that you measure the actual rate and then multiply it, you are going to be a little bit off. So technically, to get the best number, you should register or count the pulse for a full minute, because we're using beats per minute. Same thing with breaths per minute. Personally, I think 15 is quicker to assess vital signs. But if I'm taking a full set, I personally like to do 30 and 30. It gives us, to me, it's a solid number to get a pretty accurate thing. The more we divide it, the farther we are off. But yeah, there are plenty of times if I want a quick pulse, I'll check it for 15 seconds, multiply that by 4, and then have an idea and have spent less time on it. Also for me, like I just alluded to, math isn't one of my strong suits. So it's much easier in my brain to time something by 2 than it is to times it by 4. So it really doesn't matter that much. It's whatever you prefer, but there is a level, just like a minuscule level of like statistical accuracy. If someone's really sick and you need to really determine how many vital signs or what their vital signs are at, take the time to get an accurate description. But if someone's relatively healthy, you're not worried about their pulse or anything like that, you can do it for 15 seconds.
So Kevin,
sure.
In regards to the preferred time frame of being a minute to take the pulse, does that also follow suit because the rhythm can change during that minute, especially if they're under severe distress or there's something that's impacting that?
Yeah, for sure. Right? If somebody has a really irregular pulse, say they have AFib or something like that, and their pulse goes like, right? It's not going to be as simple as just checking it for 15 seconds because it's going to be wonky at that total minute or even 30 seconds. So yeah, if somebody has an irregular pulse, check it out. It's actually kind of interesting. Those SpO2s, that pulse oximetry, will usually measure a pulse too. And if you put it on someone with AFib, you put it on and you see it just kind of going all over the place because all that device is doing is using an algorithm, counting and then trying to multiply by the amount of times to get to 1 minute. So you throw it on, you're going to see 300, 0, 4, 50, 6, 2000. It just like goes all over the place because it's kind of messy. So that's a great time where I'd say, okay, let's check a pulse for a full minute just to get a good rhythm. So yeah, You guys are asking some really great questions. Good
And
job.
then if they are an AFib, how important is that number specifically, whether it's done in 15 seconds, 30 seconds, or a minute? Like, how important is that number once you've determined that they're an AFib?
I'd say it's still as important as checking anybody else's pulse. What's kind of going to be a little bit more important for us, if they have AFib, we're going to know that that pulse is going to be irregular, like it's not going to be a normal rate, but also determining if it's, I hate saying this because it's confusing, whether it's regularly irregular or irregularly irregular. So does it keep the same rhythm of being irregular, like, or does it go all over the place? Right, so like that's part of our assessment too. So there are a couple times in our protocol where specific vital sign measurements matter, right? So for me, at least, thinking about sepsis, somebody needs to meet a criteria of vital signs to be considered septic. But if we're just taking an assessment on somebody who is complaining of that leg pain, right? It's less so important for us to say their pulse was exactly 100 on the dot and they were breathing at 12 times per minute, right? We can say, yeah, their vital signs were normal. Pulse was like 70, respirate was around 14, versus somebody who we're considering to be in sepsis, where if I say their pulse was 119, that excludes them from septic criteria, right? So in general, we want to be as thorough as possible and as thorough as the situation will allow us to be. We want to keep to a good standard, and we want to make sure we treat everybody the exact same way with the exact same care and being thorough. So check vital signs thoroughly, but there are definitely times where vital signs are going to matter a little bit more than others. So just keep that in mind. And it's really going to make sense when you see the patient who's sick in front of you and you're like, I need to check their pulse. I need to get their blood pressure. I want to get a good respiratory rate. But in the long run, again, we are not doctors. If you ask me like a super medical question about enzymes and hormones, I'm going to say, ask a doctor. I'm an advanced EMT. That's just kind of how we work. We are only expected up to a level, and that's what we're expected to do. So getting those vital signs, it might not make sense to us why a couple different pulse, things matter. But if you tell a doctor those pulse ranges, it might trigger something. They're like, they have this is what's going on, or that's really important. So a lot of what we're doing, a lot of the things that we're assessing isn't for us. It's for the hospital and it's for the patient. So we just really want to make sure that it's thorough, but there are plenty of times where we can get not an estimate, but an around here. Did that help?
Yes, thank you.
Okay, really great questions, guys. I think I covered this too. Pulse. Anyone have any questions about how to assess a pulse? Oh, locations. So on a conscious, not really sick person, distal pulse on the side, the thumb side of the wrist, that's pretty standard where we assess the pulse. So if you're having trouble finding or feeling it, if you make a fist, you extend your thumb and then put your fingers right here. I can't see my own camera, but right there. That's when you can start to feel your pulse. One tip that I have is start pushing down relatively hard and then loosen up or ease up as you do, and you'll kind of feel the sweet spot of where the pulse feels strongest to you. That really works, especially with people maybe who are elderly or have a weak pulse. If you're having trouble palpating it, you can push a little bit harder and then slowly relax the pressure, and you'll likely feel it a little bit better. So distal pulse, that's pretty much our go-to if somebody is conscious. If somebody is unconscious, we're going to go to their carotid pulse. So that one on the neck here. And the reason behind that is that's the closest one to the heart. That's where it's a very high pressure vessel. So if somebody is unconscious or they're actually having a medical emergency, if we went right to assessing their distal pulse, we might not feel it. When somebody is in a lot of amount of distress, their body naturally shunts blood away from their lame extremities, the things that don't keep them alive, and puts it into their vital organs, so that you might not actually feel a pulse here when they do have a strong pulse. So if somebody's unresponsive or sick, we go to that carotid pulse. And the way to find that is you find your Adam's apple, and then you kind of just let your fingers slide into the notch next to it, and you should feel a pretty good strong pulse in there. Now, don't press too hard on yourself because I don't want to see anyone pass out right here, because you can cut that off. That's bad. Don't choke yourself. But you can feel it right there. So those are kind of like the two go-to places. Other ones that we will talk about in the future is a brachial pulse, which is kind of underneath here, underneath the bicep. We tend to do that with pediatrics. And then we can also talk about pulses in the femoral pulses. But the main ones that we're going to really worry about are the distal, the radial, and the carotid. So then a normal range here, like I said, if the younger you get, the faster it kind of goes. So for an adult, it's typically 60 beats to 100 beats per minute. We start to call someone really tachycardic. If it's like tachycardic means just like their heart rate's really, really fast or too fast where it's not healthy. That's when it's starting to get above 120. And then we start to call someone bradycardic, where their heart rate is too slow when it gets below 60. Now, there are plenty of variants here. My sister, who is an incredibly active person, exercises a whole bunch. Her pulse probably sits at around 54. And that's normal for her. Versus me, who my resting is probably somewhere in the 70s. Right, so it is a little bit important to ask, okay, you've got a pulse that's 50, you're a young person, do you exercise a lot? And they'll likely say, yeah, I'm a triathlete or something like that. So keep in mind, there is some leeway here, but in general, if somebody who is healthy is really slow or really fast, we can tell something is wrong. In general, fast or slow is very important to know. And it's incredibly important to know about kids, newborns, with their pulse rate, because one of the determinations for us is in anybody who's like a child or an adult, if they have no pulse at all, 0 beats per minute, we're going to start CPR. They are dead, their pulse needs to be brought back, so we're going to do compressions. Now, if there is an infant or like a newborn who has a pulse lower than 60, on that patient is when we're going to start cardiac, or we're going to start CPR. We're going to start giving them compression. So there is a little bit of a difference there. And we'll talk about that a bit later, but that's why it's important to know. So, blood pressure. Blood pressure is probably the vital sign that takes the most amount of skill to assess. You do have to learn 2 pieces of equipment. You do have to learn the physical skill of assessing. It does take some practice because we're combining hands-on, vision, and then also hearing to get a accurate blood pressure. So don't worry, we're going to practice it a lot. It's going to be tough. And then you're going to get out of class and you're going to start trying to take a blood pressure on an ambulance, and you're going to completely relearn how to do it. Because it's very different to take a blood pressure sitting in a quiet room versus driving in the back of an ambulance going over a whole bunch of different bumps with like a bunch of things going on. So what we're measuring with the blood pressure is how hard the heart is working to get blood through the body. So it's a combination of the heart squeezing and then the vessels and their size to receive that fluid. So it can also tell us how at risk somebody is for a certain medical condition, like a heart attack or a stroke. It can tell us, have they been bleeding a lot? If their blood pressure is really low, oh boy, they probably just don't have enough blood to have a blood pressure. It can tell us something is wrong with the heart. It can tell us a lot of different things. And we should really be trying to assess a blood pressure on people older than 3, because before they're 3, before their body starts to build to a size where blood pressure kind of matters, one, it's really hard to assess the blood pressure on a person younger than 3, and also it's not going to give us a number that matters as much as some other assessments we can do. Now, there are 2 different ways we can assess a blood pressure physically. The most common and the preferred way is auscultation. So this is a combination of using the blood pressure cuff, which is called a sphygmomanometer. I think I said that right. So we just call it a blood pressure cuff, and a stethoscope, where you pump up the blood pressure cuff and you are listening to the artery with the stethoscope, and you will determine what the blood pressure is by listening for when the pulse is audible and when it's not audible. And then the other version is we tend to do this on patients who are more severe because we can't effectively auscultate a blood pressure, is a blood pressure by palpation. And so that really just means we're going to be feeling the pulse and registering when we can feel it versus when we can't, instead of listening to when we can hear it versus when we can't. So auscultation is what we're really going to practice most of the time, but palpation is a really valuable skill to know, especially if auscultating a blood pressure has become impossible due to a litany of reasons. Here's some normal ranges. This isn't as straightforward as the other ones. Kids are kind of tricky to assess blood pressures. But for adults, the normal systolic blood pressure, that top number, is between 100 and 140. And then the normal range for an adult in that bottom, that diastolic, is 60 to 90. The ideal blood pressure in medicine, I'm sure you guys have heard it, is 120 over 80. But that average blood pressure has excluded Americans because majority of our blood pressures are not 120 over 80. Mine is sure not. Pretty much average American blood pressure is probably along the lines of that 140 over 90. With kids, one of the rules that we say is their systolic blood pressure is likely, or the normal systolic blood pressure for them is 70 plus 2 times their age. So an 8-year-old, that we should be hoping for a systolic that is roughly 86. And that would be normal for them. And then for newborns, it's pretty much impossible to assess a really good blood pressure. For kids that we can assess blood pressures on, we try to do so. We do have small, tiny little baby infant cuffs, kind of cute, but they're really hard to auscultate with. One of the main things that can really help us determine a child or a newborn or a toddler's perfusion, their blood pressure, something we call cap refill. I'm gonna see if I can get it across. Not flipping you guys off, that's my pointer. So if you can see, I squeeze my finger and I'll push all the blood out and it goes from white to back to pink. That's called our cap refill. And that's just showing us how good our perfusion is. So on an infant, if we can't assess their blood pressure, checking that capillary refill, looking for it to come back to normal in under 2 seconds, that really tells us a good idea of what their blood pressure is.
Are we not looking for a diastolic number on children?
It's really hard to assess. If we can get one, that's great. But with lower pressures, it just makes it really hard to auscultate or even palpate on a kid that diastolic. It'll make sense when we start to practice them a little bit more. But it's really tricky to get a blood pressure on a kid, especially the smaller they are. If you do end up hearing anything, it's likely just going to be the systolic. And that's okay. When we talk about palpation, like taking a blood pressure via palpation, we're not going to get a diastolic either. This is one of those ones where we would say their blood pressure is 100 over palp. We're not going to be able to get that diastolic versus their blood pressure is 100 over 60. So it's tricky to do, which is why I'm saying we really focus on that cap refill for the kids who we can't assess a full blood pressure on. Cool. So now that we've done all of these different things, we're not done, right? We have done our assessments, but a lot of our assessments kind of really only take us into the first the first couple minutes of our call, right? So we're going to do our vital signs. We're going to do our ABCs. We're going to get all that information. And then we're going to be like, great, now we've got a 30-minute ride to the hospital. Let's sit down and bring you there and let's do it again. So that reassessment, that looking for the trends, that comes from reassessment. So really what we do here is we just repeat all of the highlights of our assessment. Recheck those ABCs if somebody's really unresponsive. See if anything has changed in their vital signs. Ask them again, okay, what's bothering you the most right now? If you were having really bad chest pain 30 minutes ago, but now you're having really bad some other pain, okay, let's see what we can do. Maybe we can adjust care. Okay, that oxygen I gave you isn't helping. Maybe I can bump you up, or maybe I need to give you a medication that opens up your lungs a little bit more, right? So that reassessment tells us if what we're doing is actually helping that patient. It tells us if we're doing our job correctly and if we're actually helping somebody. If a patient continues to get worse, it doesn't necessarily mean. Am I back? Okay. It doesn't necessarily tell us if somebody's doing their job poorly, but it can just tell us that our patient is not responding well to our treatment. And we're going to need to change something, even if that small change means I tell the driver, go faster. Right, so that's the really important part about reassessment. That's us finding those trends. So steps of the reassessment, we're going to repeat our primary assessment. We're going to say, okay, how are their ABCs doing? We're going to reassess their vital signs and write them down. We're going to do another good assessment, a more focused assessment, looking at the injury or doing another palpation or something like that. We'll see how well our interventions are doing. If I gave someone oxygen, I might change it up a little bit. I might give them a little bit more, or I might put on a new intervention. I'm going to note the trends, saying, okay, their pulse is decreasing. It was originally 120 when we got to scene. Now it's sitting around 100. That's pretty good. Or patient was not breathing when we got there, and now we are giving them a ventilation rate of 10 to 12 breaths per minute via BVM. And then we can also adjust transport decision as the patient condition changes. So say that we were going lights and sirens, moving traffic out of the way to get to the hospital for somebody, and we're going to get them there as fast as we can, versus somebody who was doing okay. We were just going to take a nice, easy ride up to the hospital, and then their condition changes for the worse, and we're going to turn on those lights and sirens and get going faster based on our reassessment. Finally, we've got the paperwork, we've got the documentation. So this happens throughout the entire call, but like the formal report happens after we've transferred care over to the hospital. I don't think I've ever met a provider who did not write a bunch of notes on a pad that they had in their pocket throughout the call. It was necessary for me. If I wanted to feel confident about writing my report and also giving the hospital an accurate report of what was going on, having notes written down and just kind of the vital signs and all that kind of stuff is really important. So having that throughout the call, and then after you drop off the patient, then writing down a report of what happened, it's incredibly important, especially when it comes to medicine, and especially when it comes to life or death situations that we are involved in. If somebody was alive and totally fine before they left, and the family member sees it, and they get to the hospital and they are now dead, they are going to be looking at your report. They are going to be wanting to see it. And so documenting everything that happened, everything that you did, is incredibly important. If you didn't write it down, it didn't happen. That's essentially it. And there are times, unfortunately, where the state has to come back to providers because there has been an issue with a patient, and they say, okay, look, here's your report. You're telling us that you did this, but your report does not say it. So did it happen or did it not? And it's really hard for a provider to say, well, I just kind of forgot that we did that thing that's so important, right? I just didn't write it down. Ooh. No, if you didn't write it down, it didn't happen. So documentation is one of the most important parts here. Now, the standard that we kind of use, I like to use the most, is a chart method. We'll get into it later when we actually start needing to practice these things. But it's a really easy way of writing down what happened. You basically make a story. So C is chief complaint. They complained of chest pain. History, we say what subjectively they told us. They were watching TV when their heart started or their chest started to hurt. This is what happened, what they said. My A is the assessment. So this is what I objectively saw. This is what I observed. My R is response to treatment. So how did they do with the interventions that I gave them? And then T is transport. How did we get them to the hospital? How did they sit in the ambulance? What did you bring with them? Where did you bring them in the hospital? That kind of stuff. So it really is important to paint a good picture as if you were not the main person there. The main thing here is to make sure that it would make sense to somebody who was not on that call to read your report and have a good idea of what actually went down, what actually happened. And that is not only just important for our patient's medical records, because all of these reports are going into your patient's permanent medical record, but it's also important for legal reasons, for us. Because if we don't document something that is incredibly important, it didn't happen, and that can lead to us, one, getting in trouble, or two, hurting somebody. I'll leave it up to you to determine which one is worse.
Is there a Vermont standard used for charting, or is it specific to the group that you're working with?
So as long as you're getting across the appropriate documentation, there are other ways other than the chart method. Vermont EMS uses an online service to document a lot of the different calls. They will use something called Siren. Is it still called Siren Elite?
It is.
Good. So it's like you go through, you check off boxes, you select from lists of what the classification of the call was, and then there's a narrative section. And so that narrative section is when we use the chart method. There's also one called the SOAP method. As long as you include what is necessary and what happened and what you did, it doesn't really have to be in a specific way, but we try to make it as easy for the providers reading it as possible. So if they're familiar with SOAP and chart, and they just want to be able to find something really quick when they're looking through one of the billions of reports they have. Okay, I'm flipping through. I want something in the assessment. There it is. Because they know exactly where it is versus like, okay, what's this guy doing? I love his imagery and his verbiage, but like, man, I have no idea where any of the assessment is.
Kev, can I interject just for a sec?
Yeah.
So I would say, depending where you are, your local medical direction may have a preference. I can tell you that for those, I can speak for Chittenden County, I can speak for Southern Grand Isle County, which are all part of District 3. District 3 is the chart method. So our medical director here has specified the format that they want it in. That's not necessarily their way everywhere, but I can say that it is here.
Great, thank you.
Yep.
Can you repeat the C and H in chart?
C is chief complaint. H is history. And that history is subjective. It is what the patient tells us, where our assessment is objective, what we saw, what we measured.
Thank you.
Sure thing.
Can you repeat the R in chart?
Yep, that is response to treatment. So how did they respond to what we did? Did they get better? Did they get worse? Did they stay the same?
Do the different services have examples of reports that they want you to copy, more or less?
Well, I mean, there are plenty of like run reports that we can use as examples, being like, hey, here's a really good report and here is a not very good report. I don't know specifically about each service, but yeah, well, there are plenty of lectures that will actually have some reports in them.
Okay.
For you guys to see. Yeah.
Cool.
All right. Any other questions about patient assessments? Anything at all?
I had a coughing fit when you were talking about respirations.
Okay. That's
and,
ironic.
I know. And I missed what we look for after the noisy respirations on the slide.
Sure. Let me find it. There you go.
I can't see it. It just says screen sharing. Can I find that slide on my own or? Oh, there we go.
Yes. Oh, it's up.
Sort of. It says Zoom quit unexpectedly over it. Let me see.
It
I can,
only
I
happens.
can kind of see it. Oh, it's depth. Okay.
It only happens if I share my screen or if I turn my camera on. If I don't do any of that, we should be fine.
Aren't all the slides available through the platform?
They should also be on the platform.
Okay, I saw it on the side. Thank you so much.
Yep, sure thing. All right, what do you think, Chris? Move on?
Yeah, I think you can get started a little bit and then we can pick up in lab.
Great.
And by pick up in lab, I do not mean we will lecture in lab, just to be clear.
Yes, no. Okay, I'm going to wait for it to crash the 2 times that it does.
We see it, Kev. Kevin, are you there?
It muted me.
Oh, there you go.
Okay. So, since all of you were listening to exactly what I just said, what I said was we learned about why assessing for the ABCs are very important. Now we're going to talk about how to manage specifically the airway issues, or at least talk about, one, the structures in the airway, learning more about it, and then also learning about what we can do to help somebody with an airway issue. So we do have to start out with a little bit of anatomy. And this is what I do to make it easier for myself too. You're going to see this theme throughout my lectures as we talk about different topics. But the way I like to describe an EMT level of understanding of the human body is that it is a home, right? It is made up of everything that we need to survive. So we've got our foundation, which is our bones. It keeps us upright. It keeps us structurally supported. We've got our walls, which are like our muscles and our skin. It keeps the elements out, keeps the internals of the house nice and protected. We've got our central air system, which is our airway and our lungs. We've got the vents, which is that specific little parts, the bronchioles and the alveoli in our lungs. We got the pipes, the pumps, the water filters. We got the wiring. We've got everything. So all of this can be kind of broken down into an idea of, is it leaking? Does it need a repair? What's going on, right? Is the air broken? Is the pump broken? And as anybody can really know who owns a house or has rented something, if something goes wrong, it can either be kind of like a quick fix, or it can be catastrophic and you need to move and you need a big repair and a big renovation. So when we're talking about the airway, we're not going to be talking about the entire house. We're really going to be talking about the vents and the central air. So we are specifically talking about the airway and the lungs. So therefore, we do need to learn the structures. So the respiratory system is made up of 2 sections, and that system is what makes it possible for the body to breathe and to absorb oxygen and put out carbon dioxide. So for our purposes, we're really going to focus on the ideas of the upper airway and the lower airway. Now, it is pretty important for EMTs to have a good understanding of what the anatomy of the upper airway is, because this list is just a general, off the top of my head, the day that I was putting this together, of what I can think of why it's important for an EMT to be familiar with this amount of airway. And that is just, that's a lot of things. The airway, the mouth, the nose, and the throat, we do actually have a lot to do with. We have some devices that we can put into the nose or the mouth. We have maneuvers that we can do on somebody's body to help open the airway based off of these structures. We have medications that affect some of these structures. We have a bunch of different things that can go into this area. So these are the big ones. The main ones you're going to want to know is the oral passage, the tongue, nasal passage, pharynx, larynx, epiglottis, esophagus, and trachea. And that's a lot That's okay. I'll go back to the other one in a minute. I just wanted to see what it actually looks like in a cadaver. So that's what our airway looks like. Here's our nasal passage, connects to our oral passage. There is our epiglottis. And there's our trachea and our esophagus and our larynx and our pharynx and all of it. So I'll go back here for a little bit. So that nasal passage is really up into our sinuses and also connects down to the back of our throat and our pharynx. So those words, which we're going to talk about, nasopharyngeal and oropharyngeal, they're talking about the space that is kind of between the nasal passage and the pharynx, or the oral passage in the pharynx. Now, the tongue is a pretty important piece of equipment here. It's a big muscle. It can also kind of block our airway. It's not as common as people think to hear that whole, oh, they swallowed their tongue kind of deal, but it is pretty common for the tongue to be a partial obstruction of the airway. That's when we hear snoring respirations in somebody. If you hear somebody who's snoring, if they just sleep with a snore, they have a partial obstruction in their airway. I used to have sleep apnea, and I had massive tonsils and adenoids, and the doctor said they were in the top 3 biggest that he's ever seen. I snored like a freight train, and I woke up 50 times an hour when I slept on my back subconsciously because I would suffocate myself just based off of position of rest. So it's potential for your own structures to be a little bit of an occlusion to your airway. So just keep that in mind. So with our pharynx, that's kind of that area at the back of our throat in the upper airway. The epiglottis is a flap of skin and cartilage that controls what goes down which tube. So our esophagus, that's where our food goes down, and we definitely don't want food or water going into our lungs. So that epiglottis acts as a flap. When we swallow, it closes and lets stuff go down into the stomach. And when we're talking, we have a deep breath that allows air to go into my lungs. That is really important because there are some life-threatening conditions involving the upper airway, specifically the epiglottis. So knowing where it is and how it reacts is a pretty important thing. When we're talking about our larynx, that's really it's the term for our vocal cords. So right at the top of our trachea where air comes through, it's how I'm actually talking to you guys right now. They are making a bunch of weird motions. Our trachea is this kind of ringed structure made of cartilage that is strong for our airway, where our esophagus is kind of like it's just like a mesh, or not a mesh, it's like squishy, right? It sticks together, whereas our trachea is solid, so it stays open all the time for air to get down. Our esophagus kind of works the food down by contracting. So our trachea is solid because it needs to stay open and be protected, whereas our esophagus doesn't need to be protected as much as our trachea does. Okay, so this upper airway, these are the structures you really want to know. And here it is on a real human cadaver, cut right in the middle. So as you can see, same thing. There's that epiglottis. There's the ring structure of the trachea. There's the esophagus, larynx, the pharynx, the passageways, and the tongue. The lower airway, we have less to do physically with. We're not going to be in there as much as we are going to be with the upper airway, but we are going to be assessing for and hopefully fixing some issues with it. So the lower airway consists of the lungs, the bronchi, and the alveoli. It's essentially what we're really concerned with. So the bronchioles and the bronchi are the tubes from which the air goes through. So they break down from bronchi to bronchioles. Bronchioles just means smaller bronchi. So these big trunks right here are bronchi, and then as they get smaller, they become bronchioles. So that's the physical passageway. They're made of cartilage similar to the trachea. They are the physical structures that allow air to get into the different lobes of our lungs. So the arteries and veins that run through our lungs and absorb the oxygen-rich blood now, those are also very important. If there is an obstruction of those arteries or veins, the oxygen from that portion of the lobe of the lung is not going to get back into the bloodstream and not back to the brain or to the other important organs. They're also held in place by ligaments, just to keep them where they are. And there's also a thin lining of the tissue around it called the pleura. There are some differences when it comes to the left and the right lung. For the most part, we're kind of symmetrical. Not really when it comes to our internal organs, except for our kidneys and stuff, but our lungs, they are pretty symmetrical, except they do have some differences. So the right lung has 3 lobes. It has an upper, a middle, and a lower, where the left lung only has 2 lobes, an upper and a lower. Does anyone know why that is?
Heart.
Yeah, the heart sits right there on towards the left side. Kind of looks right for, that was on my right. So on the left side, sits kind of in there. So the lung needs to kind of adjust its shape so that the heart can actually fit in there. If it was the same size as the right lung, it would actually put some pressure onto that heart, which would not be good. So that's why our left one has a little bit less surface area, but it still functions just as well as the right. So the main structures here for you to know are the bronchi, the alveoli, and really just the lungs. Oh, look at me, I'm smart. I had that on my next slide. So here's just a cool picture of lungs inflating. So as you can see, they can get pretty big. They are just like meat balloons. They just fill up, expand to their sizes, and then we breathe out and they go back. And this is from the back. So this is what your lungs look like from the back, not from the front. It's kind of cool just to look at. So another structure is our diaphragm, or diaphragm, as some people say. That's why I put the thing up here. It's a dome-shaped muscle. If you guys are unfamiliar with domes, I do have a list of famous domes here for you that might help. So it divides the thorax from our abdomen. So it's kind of that line where we can say, okay, our thorax, our chest between our abdomen. So it's kind of got this layer. It wraps up underneath our ribs. And it's really what helps us breathe. It's a muscle that allows our chest cavity to get bigger, to allow more air and to allow our lungs to expand. And then it relaxes, goes back, and it keeps our, reduces pressure in the chest and makes us exhale. So inhalation, we'll see the diaphragm move down, allowing more space and creating a pressure into the lungs. So we create a negative pressure to inhale. So it goes down, air comes in, we reach our capacity, and then when we exhale, the diaphragm relaxes, it comes back up, contracting our chest and pushing air out. We technically have to exceed atmospheric pressure to breathe in because we're causing air to move, and same thing, we do have to exceed atmospheric pressure to breathe out. It's not that hard for a healthy person, but it can get really challenging for somebody who's having a respiratory issue. So we can take breathing pretty for granted because right now where it's all pretty easy for us, our diaphragm's not doing anything weird, our bronchioles aren't doing anything weird, but it can change pretty quickly. So, respiratory physiology. This is kind of a tricky, not a tricky subject. This is a little bit more of one of the complex areas that we're talking about here. This is probably one of the areas, besides pharmacology with the medications that we're going to get into, that we do have to get a little bit more nitty-gritty about percentages of molecules and what is actually happening. So respiration and the physiology behind it is when we're talking about oxygen molecules being absorbed through the body into the bloodstream, where they are then transported to the rest of our body. In this same motion, we are getting rid of carbon dioxide and breathing better. So as you can see here, when we breathe in, we're roughly taking in about 20% oxygen and 0.4% carbon dioxide. It goes down through the bronchioles into the alveoli, where it is absorbed, transferred into blood, and then the air now contains carbon dioxide. And when we breathe out, we have less oxygen because we've taken it in, and we have more carbon dioxide because we have put that out. So when I say respiration, I'm talking about a chemical action, a molecular level of interaction within our lungs. And when I say ventilation, I'm talking about something else. So that's just a cool picture also of all of the different structures and how little they can get. But respiration is the exchange of oxygen and carbon dioxide in the alveoli and the tissue. It diffuses through the blood, and our brain stem controls how fast we have to breathe. It measures the amount of oxygen in our blood, and if it's too low, tells us to breathe faster without it having to communicate that to us. It just does it. And if it's too high, it tells us to breathe a little bit slower. Now, ventilation is the physical act of air moving in and out of the lungs. So it requires chest rise and fall. It requires the diaphragm to move at a certain depth. And some of the things we talk about when we talk about ventilation is something called tidal volume, which really is just the general term for the amount of air moving in and out of the lungs. We can also talk about minute volume, which we don't really have to worry about too much because we don't really have a way to measure someone's exact tidal volume to multiply it by the respiratory rate to get a minute volume. That's something that a respiratory therapist will really take care of. We're more concerned about, are they actually being ventilated enough? Are they breathing in enough air for it to help them survive? So some ways that we can think about this, ventilation is really just mechanical. It is physical, right? It is like an air pump. It is like a balloon. That is ventilation. Respiration is metabolic. It is down to that little cellular level of what's going on. It's about blood. It's about the percentage of oxygen in blood. And it's about just physically the metabolic procedures actually working. And that's going to play a big part in our assessment. Determining if somebody's having a respiratory issue versus a ventilatory issue can be a big deal. If somebody is breathing 12 times a minute, but their SpO2 is in the dumps, they've got blue cyanosis around their lips, they are pale, they're sweaty, right? That tells us that they're having a respiratory issue. They're getting air in, but they're not getting the oxygen, versus somebody who's breathing 4 times a minute because they're unresponsive and overdosing on opiates. That is a ventilation issue. So what that means for us here is that for ventilatory issues, we're going to need to breathe for them using a BVM, like this guy is using in this handy dandy video. He is physically forcing air down into the lungs to force them to expand. So if somebody isn't breathing, we can breathe for them. Versus a metabolic intervention, which might be as simple as oxygen. Hey, you're not getting enough oxygen. Let's amp the percentage of oxygen in your lungs so that maybe your body will absorb some more. Or hey, maybe there's a structure in your lungs that we can give you a medication for to open it up to give you more respiration. That makes sense to everybody? Cool. We did just talk about this a little bit. So here are some normal rates. 12 to 20 for adults is the main line there, and then the younger you get, the faster it goes. And here's some medical terminology for you. We got tachypnea and bradypnea. The prefix tachy means fast. The prefix brady means means slow. And the ending means, the pnea means breath or air. So these two together, it means fast breathing or slow breathing. So the danger zones for us, technically anybody who is above 20 breaths per minute is tachypnic, and anyone who's below 12 is bradypnic, but we really are worried about the danger zones. So if somebody's exercising, right, it's totally normal to breathe above 20 breaths per minute. If someone's nervous, same thing. But if someone is having a medical issue and they are breathing 35 plus times a minute, that is a major danger zone. Same thing with less than 8 breaths per minute. There's a saying that we say, it's called less than 8, ventilate. So if someone is breathing less than 8 times a minute, they likely will need us to use a BVM to ventilate them. Now, It's more of a challenge to ventilate somebody if they are breathing really fast, but there are some times where a fast or a tachypnic rate will mean that we need to ventilate somebody. But it is typically more common to ventilate somebody who has a low respiratory rate, who is not ventilating enough. So that's when we can actually get into determining what is good breathing, right? So if somebody's alert, if you can see them breathing, it's a regular rhythm of inhalation or exhalation. You don't hear any weird sounds. Their chest is rising and falling without difficulty. You don't see any other structures forcing it to go. They got an adequate depth and no abnormal breath sounds. So it should look pretty much like this, right? Just a standard breathing pattern. But ways that we can determine if it's really bad is likely they're going to be agitated, because if we don't have enough oxygen in our body, we tend to get grouchy. They'll either be unresponsive or dead. If somebody is not breathing well enough to the point where it can get really bad, they will be unresponsive. And if they are not breathing well enough for a long enough amount of time, their heart will stop and they will die. Now, some other terms we're going to talk about here, the medical terms. We've got dyspnea versus apnea. So dyspnea, as you guys can recognize, I hope, it's the pnea, that ending that right there means breath. That dys means difficult. So dyspnea means they're having trouble breathing. They're having difficulty breathing, where apnea just means they are not breathing. A means absence of, so apnea, absence of breath. So this is a big deal to me, because there was one time I was dispatched to apnea and I got there and they were just having some shortness of breath and it was dyspnea. And when I got back and was talking to the dispatcher, they were like, it's the same thing. It's not. So dyspnea is difficulty breathing and apnea is lack thereof. So somebody who's having difficulty breathing, yeah, I might be concerned. Right off the bat, I don't know if they're a high priority patient, but somebody who's apneic, definitely a breathing and airway issue. We need to fix that right now. They are likely in cardiac arrest. Some other things that we can see that really help us determine if their breathing is inadequate is abnormal sounds. So a common one is wheezing, right? Some people wheeze when they laugh, but if somebody has asthma, right, you can hear it wheezing in their lungs. Like you take a breath in and it's like kind of delayed. Right, you take a deep breath in and you can hear like in their lungs, or when they breathe out, you hear that whistling kind of popping sound. We can also hear snoring, like I talked about, so a partial airway obstruction, usually the tongue. And then stridor is another upper airway partial obstruction. We'll talk about it a little bit more when we get to respiratory emergencies, but it's kind of like this squeaking kind of barking kind of sound. So those are the abnormal sounds. And abnormal sights is a tripod position. So if you guys remember that image I showed you of that gentleman closer to the beginning of the other presentation, he was sitting in that chair, pursing his lips, hunched over, clutching his knees. That's what we call the tripod position. And that actually really helps somebody who's having difficulty breathing. If you have ever been an athlete or you've run distances or been winded, right? One of the first things you want to do is just lean over and put your hands on your knees. And it's kind of just a normal reaction, because what we're doing is we're using gravity in our bodies to help us breathe a little easier. If we're leaning forward, we're taking the effort off of our lungs and our diaphragm to actually expand our chest. We're allowing we're allowing gravity to take it down for us. So that's a really good indication that somebody is having difficulty breathing if they're in that position and they say that it's helping them breathe. Other things here are that cyanosis, that blue tinge around the mouth, in the gums or the fingertips. And then sternal or substernal retractions, accessory muscle use. So the muscles in between our ribs, if somebody's muscles in between their ribs are really clenching and trying to force their chest to close, that tells us they're pretty late into respiratory distress. It's a bad sign if those muscles are trying to kick in to help you breathe. And then some other things here, we've got the different breathing patterns. So we've got something called Kussmaul breathing, which is really just fast and deep. So if somebody was breathing like like that. That is a Kussmaul respiration versus a Cheyne-Stokes, which is periods of really fast breathing followed by no breathing at all, followed by really fast breathing. It's kind of one of those patterns we see. Kussmaul breathing usually comes about in a hyperglycemic event, so somebody who has too much blood sugar. And then typically we tend to see Cheyne-Stokes in people with head injuries, whether it's traumatic or a stroke. So those are some other assessments that we have. If somebody is unresponsive and they're breathing really deep and really fast, it might tell us, hey, we should definitely check their blood sugar. Also, another good one here is an agonal gasp. It looks like a breathing pattern, but it's actually a sign of cardiac arrest. I actually have a video here, I think. So other ways to tell. Pale or cyanotic skin. They might be cool or clammy to the touch, a little bit sweaty and a little bit cold. They'll be sitting in that tripod position and they'll have those accessory muscle use. There's some cyanosis for you. We do have to ask though, did you just drink blue Gatorade? Here's some central cyanosis on somebody who has a darker pigment. So you can see it still comes through on the tongue, and you could likely use underneath the lips or even their lips to help you determine. There's a drawing of the tripod position. Let's see if it loads. Oh, good. Here are some retractions. So these are the muscles in the chest helping the ribs close and squeeze the air. So this kid is having a lot of difficulty breathing. He's also being ventilated. So just look at the retractions on his chest.
This video was taken from...
Okay, I don't want to hear that. Can you see the muscles helping it contract? You can see his ribs are bending to help do that. You and me, if we're breathing normally, our ribs don't have to do that. But this kid is in such severe distress for such a long time that the body is now forcing those muscles that don't really usually kick in to help this person breathe. Okay, that's a bad sign.
This video was taken from YouTube.
Now, agonal gasps, and this is the last thing I'll show you guys, and this is a fake video. This is a really convincing actor, though. This is what agonal gasps look like. This is somebody going into cardiac arrest. So if we see this on a patient, it actually doesn't indicate that they're breathing. It indicates that they are in cardiac arrest. This is the body's last ditch effort to try to get some respirations in. And then after this, I'll open up the questions and we will be done. So again, that's fake, but he does a very convincing job. That is what agonal respirations look and sound like. So if somebody is doing that, they are likely in cardiac arrest. So don't take that as somebody breathing, take that as they are dead. Okay? Cool. We don't need to watch it again.
Yeah, this might be a good place to stop.
Yep.
All right. Did folks have any questions for Kevin?